think they've turned on the, oh, I hear it.
Hi, everybody. Hi. So I want to introduce Dr. Sean Young. Dr. Sean Young is the Associate Professor of Family Medicine at the David Geffen School of Medicine at UCLA, and he's the Executive Director of the University of California Institute of Prediction Technology, or UCIPT. And UCIPT, we conduct research and we do educational events, like this hackathon, for instance, to study and teach different ways to create innovative solutions to address the most pressing public health problems going on right now. And so, with no further ado, please welcome your host, Dr. Sean Young.
Good morning, everyone, and welcome to the Opioid Symposium and Hackathon 2018. As I was going through the list of attendees of the event outside, it reminded me of a story about a research professor, and she oversees a big institute with different areas of research, and she's walking through a park. And as she was walking through the park, she was with two of her staff. One is a graduate student in data science, and another is a postdoc in medicine. And as they're walking along, they see there was a lamp on the ground. And having heard stories about what you do when you see a lamp, they pick up the lamp and they rub the lamp, and out comes a genie. And the genie says to them, I will grant you 3 wishes. What do you wish for? And the graduate student data scientist says, me, I want to go first. I want to go first. Okay? Graduate student data scientist, what do you wish for? And the graduate student says, I wish that right now I was on the beach in Hawaii just sipping Mai Tais and relaxing. And the genie says, all right, graduate student, your wish is my command. And poof, the graduate student's gone. Genie says, who's next? And the postdoc says, I want to go next. And so the genie says, what can I do for you? And the postdoc says, I want to be on the beach in Mexico, drinking margaritas and listening to the ocean and just relaxing. And the genie says, your wish is my command. And poof, the postdoc is gone. And then the genie turns to the research professor and asks her, what can I do for you, professor? And she says, I want both of them back after lunch. Now, it's a joke, but I think it highlights an important point and something that's going to be a big emphasis of the next 36 hours. And that's, we cannot do things alone when we're trying to solve problems. We need teams, we need diverse teams. And this is especially important when we're trying to solve extremely difficult and impactful problems. So for example, every day in the United States, approximately 115 people die from opioid overdose, making it right now the top public health concern in the United States. For a number of reasons, we lack the data and tools to be able to solve this problem the way we need to. Now, our group at UCIPT, we try to work on data and solutions and tools with groups like public health departments to help solve real-world problems like this. And this event, the symposium and hackathon, are part of our efforts to try to help address this problem. So for the next 36 hours, we're going to have this symposium to begin with in the morning to teach attendees, especially the hackathon participants, about the opioid crisis. And then after the event, we'll open it up to a hackathon where teams will compete against each other. 25 teams that we've picked will compete against each other for prizes and different types of incentives to try to develop solutions that can be implemented to help address the opioid crisis. We have, in the morning session, you'll be able to hear from a group of experts in medicine and public health about the opioid crisis. How did it begin? What is the background on it? What are our current trends? You'll hear from researchers in data science, in behavior change research on tools that have been applied in other areas and how we might apply them here. You'll hear from implementation scientists talking about how to study and how to implement approaches like this. And you'll hear from a woman who lost her son and how she's, as a result of losing her son to opioid overdose, she's been able to start an organization and be able to have an impact on preventing this from happening to others. This would not be possible without our organizing team. I want to thank our team for helping to put this on. Claire, you've spent countless hours on this. Thank you. I want to thank our advisory board, a mix of people from very diverse backgrounds and expertise. And I want to thank our sponsors who have put in either time and effort and/or funding to be able to make this event happen. Now, one particular funding source I want to highlight and thank is the National Institutes of Health, including National Institute on Drug Abuse and National Institute of Allergy and Infectious Diseases, because there is a special carve out of funding that they provided here for this event and the follow-up from what's called the HEAL Act, Helping End Addiction Long Term, which is a new federal act based on the opioid crisis and putting aside funding for studying after this event, how can we really change the way public health is done in potentially using hackathons as a method to scale and implement solutions much faster. Now, you'll hear from a lot of serious topics throughout the morning, so keep this a little bit light. For many of us in public health, I think we're often used to having a lot of meetings, and at the end of the meetings, we're not able to solve the problems to the extent that we often want. That's one of the purposes of this event here and that funding that I mentioned from the NIH. We want to be able to study whether we can take creative groups of different individuals from different backgrounds, data science, patients and families impacted by the opioid crisis, public health and medical professionals, be able to take all these groups together and have them compete on teams within just 24 hours and see if that is a way of potentially changing the way we address public health problems and see if we can reduce the time that it takes to address important public health problems. So let's get to the tracks of the hackathon and what will be happening later this afternoon. We're going to have 4 different tracks of the event. 2 of them are going to be focused on software development. So the first one, infrastructure and application interfaces for ethical and secure sharing of opioid-related data among key stakeholders. So this will involve technologies and interfaces that allow patients and families to share data and be aware of the risks of doing so, public health researchers and government stakeholders to be able to have access. Second track will be designing personalized behavior change apps that can be applied by patients or their families, providers, and health systems for long-term reductions in overdose-related behaviors. So for example, in behavior change research, we've gotten very good at being able to nudge people to do something once, but not as good at being able to sustain and get people to keep doing things. That's what this track is going to be focused on. Second 2 tracks will be focused on data science, artificial intelligence, and visualization. The first one being focused on public health departments and finding real-time prediction models and visualization tools to help prevent addiction and overdose. The second of those 2 tracks will be focused on real-time prediction models and visualization tools, showing new integrative therapeutic benefits and approaches to prevent addiction and overdose. So this one will be similar to the previous, but focused on new approaches like cannabis and virtual reality and augmented reality. Now, how are we going to, for teams to solve this within 24 hours, obviously takes a lot of creativity and diversity. So we will be providing these diverse teams access to, as far as we know, the largest opioid-related data set of its kind in US history. Teams will get access to more than 150 opioid-related data sets. And many of these will be hosted on Socrata, on our partner sponsor site who's provided support for this. We'll also have a number of other data sources, some open data sources from local government sources and state and federal sources. We'll also have companies, for example, cannabis companies who've provided proprietary data on things like cannabis dispensaries, locations, and sales. Now, we have to have diverse groups and mix of teams to be able to solve this important problem. So we have a distribution where we have about 75% right now of technical or engineering backgrounds of the teams, along with 25% mix from public health, patients' families, and other government backgrounds and key stakeholders. We also have a mix. We have about 50% of teams coming from industry, from large corporations as well as from startups. And we have a mix of the rest from teams from academia, from places like schools like UCI, UCLA, Stanford, and even overseas. And we also have a mix from government, public policy, and public health and medical area. Now I'll stop here, and I just want to encourage everyone to get involved. If you are interested in helping to try to make an impact in this area, you can write to us at Predict Tech. Please use the hashtag if you're tweeting the Opioid Hackathon 2018. A reminder for everyone that this event is being filmed and this morning is being live streamed. Please talk to us if you have any questions about that. And we hope that all of you will learn a lot in this morning's session from these experts, and that you will use this information to really try to work together and make an impact. With that, I want to turn to our next speaker, our next welcome. And this will be coming from Washington, D.C. With the assistance in planning this event, we have the U.S. Department of Health and Human Services. And I'd like to give a warm welcome, everyone, to Letitia Ingram, coming from HHS on behalf of our partner in organizing this, the Chief Data Officer of U.S. Department of Health and Human Services, Mona Siddiqui. Everyone, welcome Letitia.
Good morning. Thank you for having me here in sunny California. Emphasis on sunny. My name is Letitia Ingram, and I am a public health analyst in the Department of Health and Human Services with the Office on Trafficking in Persons. And I'm here today to talk about creating value from data at HHS. Before we get started, I just wanted to kind of put out a couple of things to help you understand the context from where I'm speaking from today. So most of you are familiar with multiple areas of HHS, and you may not know it. The Department of Health and Human Services is comprised of several agencies like NIH. You may have also heard of the Centers for Disease Control and Prevention, the Health Resources and Services Administration, which serves the community health centers, as well as Administration for Children and Families. And this, along with staffing and operating divisions like the Office of Minority Health or the Office of Women's Health, comprise the Department of Health and Human Services. As I talk to you today, I'd like to emphasize a couple of qualities of the data analyst and talk to you from that perspective. And I'll give you a little bit of a snippet of what may be those qualities that you might see in a data analyst. One of those qualities is that they are fiercely passionate about the programs that they work for. They are generally persons who spend late hours making certain that the data is accurate and that we are able to provide timely responses to our secretary or communities and grantees that we are serving. The second quality is that we are, as stewards of the federal government, we see a priority in being able to support patients, the persons that we serve, and to protect the data. That comes through a number of laws and regulations that may be sometimes in conflict with what we are able to produce and provide to the larger community. But regardless of those sometimes polarizing characteristics, we all have a vision. And this is a vision that actually came out of the Reimagine Data Initiative, or the Data Sharing Project. And as you can see, our vision is an HHS where data are shared, connected, and analyzed in a responsible way. But sometimes for this project, it's really about operationalizing what that means in the department. How does this happen? What are the barriers and challenges in the way? And how are we able to develop a comprehensive plan in order to address those issues? So another key underlying foundation for the Department of Health and Human Services is that we realize that data is a valued strategic asset. And by that I mean, for example, whether it's an outbreak and detection and response that came out of the Centers for Disease Control, or perhaps a biomedical research from the NIH, or even program evaluation from the Administration for Children and Families, data is the undercurrent that informs public health interventions and actually helps us understand program decisions in a way that impact lives. So without the right data, or even without quality data, we're at a stopgap and unable to do the work that requires us to move forward to innovate. So a wonderful event happened, actually under the leadership of Dr. Mona Siddiqui, the Chief Data Officer for the U.S. Department of Health and Human Services, also being supported by the Chief Technology Officer. We held a series of events back in December of 2017. This opioid symposium and codathon had a unique theme, and it was the first of its kind in the Department of Health and Human Services. Our theme was connecting data to save lives. And the opioid crisis, as you know, is very important because the HHS has a unique role in educating persons and communities through the programs that it already serves. We serve the rural. We serve sparsely populated populations. We also service persons who are medically underserved, the vulnerable, and at risk. But by also using those as in-ways or entrees to those communities that are best served, we have a very unique role in actually spearheading and moving forward the agenda of addressing the opioid crisis. So led by Stanford Medical X, HHS held a design-a-thon to engage stakeholders in brainstorming design solutions. So outputs from the design-a-thon actually informed the judging criteria for a codathon. The second set in this series of events was an HHS symposium, and it brought together leaders in the front lines of the opioid epidemic for TED-style-like presentations, and also panel discussions showing the promising practices in the opioid crisis. And finally, a codathon. A codathon itself was attended by 49 coding teams that were competing in person over a 24-hour period. Now, those as this codathon were represented by persons from technology, nonprofit, some industry startups, as well as academicians. And the winning teams from each of the challenges, or each of the tracks, which were prevention, treatment, and usage, those winners went on to win $10,000. But the huge win for the department was larger than this, because what we benefited from was a multitude of technology solutions that actually impacted not only patients, but providers, state health departments, as well as departments of health. Now, the larger win is that we have some lessons learned that came from this codathon. The codathon actually was a vehicle for us to rapidly realize and provide and get evidence on the challenges in accessing data and ensuring quality data. This event actually catapulted HHS into a learning mode. And so our focus began to turn to how do we address these challenges? Are we right about what we found? These challenges came up because of the codathon, but are these actual real challenges for HHS? And so the work began over a summer of a very intense semi-structured interviews with the senior agency officials identifying data sets of value, of most value to the department in this area. We conducted that work over a time of a very intense time frame, about the summertime, collecting data, collecting information about the metadata that's being structured, how the data was being stored, what are some of the technical aspects, but also really pointing to and understanding some of the cultural norms that undergird how data is shared in the department. And Just last month, the department released 2 key reports. The first was the current state report of HHS data sharing, and it identified 5 key issues. One was the process for data access. We found that there was a lack of consistency and standardization and even transparency in how data requests are being handled. The second was the technology, that there's variation amongst the various formats. If it's a survey from NIH, it may not match up with the Centers for Disease Control. Some of the way the information was even stored provided challenges in being able to provide that to the codathons participants. Another key aspect is the regulatory environment. When the use of data use agreements is a problem not only for the states, but also within the Department of Health and Human Services. The disclosure risk management, something that's on every data analyst's mind. How do we protect the personal data that the patients are willingly providing us and ensuring their privacy? And finally, the real big one was the norms and resource constraints. Not only are data analysts very protective of the data that's actually being collected, but there's also a fear that sometimes the misinterpretation of that data by giving it to a second party could come back to reflect poorly upon the program. There's also strained resources. That data analyst that sometimes spends an inordinate amount of time analyzing data, making certain it's clean, can be sometimes overwhelming to that person, and if there's not enough persons that are actually understand, it creates a burnout. The third effort here is a future state report that we're currently in the process of developing. And from the current state report, it goes a step further in identifying some of the key practices that already exist in the department that had not been known by our other partners or other agencies, and our inability to share the data. So by taking these issues and challenges and turning them into recommendations moving forward, we're up to developing a comprehensive plan that will be reflected in a future state report. So where we are now, and I hope this is kind of clear and hopefully depicts where we are. If you can see this image behind me, there is a silo. And within every silo, there's a program. Within every program, there's a data set. And they're pretty much organized within the agency, in some cases not. But ultimately, for us to come up with a comprehensive perspective, we've got to get to one jar where all of the organized data sets are organized and being able to access them in a timely manner. And we know that there are some key steps that have to happen as we develop this plan in order to get there. One of those is reducing the redundancies in the type of analytic tools that we have. We pay multiple vendors for the same licenses over and over again across the agencies, not as cost efficient as it could be. Eliminating numerous interagency data sharing agreements. Reducing costs associated with multi-purchase analytic tools, maximizing informed decisions and policymaking, and ultimately demonstrating measurable gains from this collaboration and a return on investment. So all of this we hope can be addressed by having a comprehensive plan that will take into consideration all the challenges that have been identified and move the needle forward for us as an agency. But in the end, what we all want is for HHS to be able to access quality data that can provide a holistic view of the problems and evidence-based solutions. What does success look like for us? Here are a couple of components. Most of them are very small pieces of three basic areas: people, process, and technology. And these are what they resonate for us as tangibles that we know must occur. But the larger piece of this is something that we're going to actually tackle that's actually is more important as these tangibles. And one of them is engaging the end community. The federal government and our peers, those data analysts, are our end community. And have they had a voice in being able to determine it and help guide some of the, to articulate the data sharing challenges as well as some of the solutions that could be part of that. This second part is a focus on value and quality to the department, as well as constraint mitigation. Something that we sometimes will get stopped like anyone else, but how can we actually put in strategies to address those constraints? And empowering individuals in interactions, even as we develop processes and tools. Sometimes the individual is part of that, is not part of that, and we want to be able to move that forward. And also customer collaboration. The agency is a customer, and we need to work together more, and that's what we're up to. So success for HHS is being responsible and collaborating on insights that really matter and make a difference. I want to thank you for your time this morning and listening, and I'm going to enjoy sunny California.
All right, thank you, Letitia and HHS. Next up, I'd like to invite, coming from Marin County, the Public Health Officer, Dr. Matthew Willis.
Thank you. Thank you. Can everybody hear me? So we've heard the federal, I can't, I am tied to the podium. All right. So you've heard some from the federal perspective. I'm going to offer the local perspective on this. I am a local public health officer. I work in Marin County. We've been grappling with the opioid epidemic now for the last 4 years as a public health priority. I'm also an internal medicine doctor and have been part of the problem. My experience with the opioid epidemic, and I think all of us in some way are living this epidemic now because it's so prevalent, began about 20 years ago when I was in medical school. And was beginning to be taught in that context to make sure that for every single patient we were soliciting any possible experience of pain they may be having on every visit. And combined with that was this other message that was intended to be a reassuring message to us as physicians, which is the good news is that there's a safe and effective and affordable remedy behind you on the shelf. There's opioids that you can easily prescribe to these patients. And over time, over about 20 years, that led to a history of overprescribing, frankly, among the medical community. And we are just beginning to now try to unbury ourselves from under this. So over that period, between about 1999 to about 2010, we rendered an entire cohort of individuals addicted to opioids, partly because of primary care and normal allopathic medical practice. There are now efforts to try and reduce overprescribing, and one of the things I'll describe is our safe prescribing efforts. Since then, now as a primary care doctor, when I actually graduated from residency and became a physician in Marin County, I recognized that those patients who had been prescribed opioids may not be having the benefit in their lives that we had expected from that. And in fact, some of my patients had experienced overdoses themselves. I then moved into primary care, into public health, and as a public health officer, I ended up having a chance to look at this from a wider lens across the community and seeing the data that was available to us countywide and recognizing that opioid overdose were in fact, back in 2014 and remain so, the leading cause of accidental death in my county, with one accidental overdose to opioids every 2 weeks in Marin. As we're seeing now in the nation, that translates, there's 72,000 deaths last year to opioids, which is 1 every 10 minutes. So by the time I'm done with this part of this presentation, there will have been two, if we average that out over time, 2 individuals who will have passed somewhere in the United States due to a preventable, what I see as a preventable overdose event. So that's some of the context for my lens. So I have a very practical need for solutions. And I think we're my hope is that this hackathon will actually lead to solutions that we can implement at the local level in the short term, because we don't have time to wait. This was an interesting analysis that was done about 2 years ago that basically forecasted different scenarios for the opioid epidemic. The top trajectory there was, if we don't do anything differently, what can we expect in terms of the number of deaths we'd see over time? On the one axis, you have time down to 2025, and the other axis, you just have the number of deaths that we would expect. Modeling the current trajectory, obviously, this was done 2 years ago. We are actually on track. In fact, we're actually doing worse than even that worst case scenario that was projected 2 years ago. And that's partly because of the changing nature of the epidemic and the introduction of other agents like fentanyl and illicit opioids. What's important about this is that the most optimistic scenarios, those scenarios where we actually start seeing over time decreases in overdose deaths, make an assumption that we are making success and progress in multiple domains at once, so that we are actually achieving those safe prescribing guidelines more reliably each and every time we're prescribing opioids. That patients have opportunities to safely dispose of medications each and every time. That people who are addicted to opioids have access to treatment that they need. That naloxone, the medicine that can reverse an overdose when it occurs, is available in a timely way on site. That some of the stigma around addiction has been relieved. And it's only through a combination of all those strategies occurring simultaneously and in parallel can we actually expect to see this kind of success even over the next few years. This was, you may have seen just the more recent CDC report, 72,000 deaths in 2017. So despite all of our efforts, the epidemic actually continues to accelerate. At the height of the AIDS epidemic, any idea how many deaths? We had about 55,000 deaths. I think about 1995 was about the peak. So this is worse than the biggest plague that we've really experienced as a nation, and it's continuing to accelerate. This was an analysis I want to share with you that was done, published in the New York Times recently. Dr. Dan Ciccarone, who's an addiction specialist up at UCSF in San Francisco, partnered with the investigative journalists at New York Times and basically asked 30 experts in the field at the national level. So these are people who were in social services and law enforcement and public health, in other domains of civic service. If they had $100 billion to spend, where would they invest it to address the opioid crisis? And and this was the consensus, this mosaic. It was sort of like the relative attribution, or the amount that each would sort of allocate, averaged. And what you see is about half was dedicated to treatment, about a quarter was dedicated to reducing demand for opioids through community development and other strategies. And then for the remaining quarter, we're divided between harm reduction, so that's the naloxone, which I'll talk a little bit more about, the medicine that can reverse an overdose when it occurs, and then reducing supply through precision monitoring and law enforcement efforts. So the point is that there was consensus among the experts that we need to be working in multiple domains at once to address this issue. And what we don't have right now, and I think it was alluded to by Health and Human Services, is infrastructure, even data infrastructure, to integrate these strategies that need to be incorporated at the same time. None of these will be sufficient in and of themselves, but all of them will contribute in some way to the solution, even if they're done individually. Obviously more effective if we're able to integrate our strategies in a coherent fashion. And one of the jelly beans need to be together in the jar, right? So this is suggests that we need a collective approach. I had a chance to be in Atlanta in 2016 when President Obama was present at the National Drug Abuse and Heroin Summit. And basically his call to action was we need an all-hands-on-deck approach that says all of us are working together in order to address this problem. And then on a more academic side, the Institute for Healthcare Improvement that's done a lot of interesting work on this, did an analysis in 2016, and their conclusion was the epidemic will continue to worsen in the absence of coordinated and collaborative community-wide approaches, which essentially means that we need to be functioning differently. Coordinated and community-wide approaches means that we need to be outside of our silos that we normally engage in, right? So it's not healthcare, right? And what I've observed is that our hospitals like to sort of try and develop their own solutions to this. Our law enforcement people like to have their own idea of how they want to approach this. But we need to make sure is that we're actually having those conversations across those sectors. One way that we're doing that in California to have these integrated community-wide conversations, and I think this is important for you as participants, when we think about the implementation of the tools you may develop, you have allies in the field right now who are eager for whatever tools you may develop, and they are coalitions across the state that are designed at the local level and is part of the California Opioid Safety Network. So if you're imagining your sort of user, this is one potential ally for you. Most California counties have opioid safety coalitions that are functioning at the local level that integrate educators, law enforcement partners, elected officials, hospitals, healthcare systems, because of the complexity of this and the fact that we need to make sure that we're actually working at the local level. It's local solutions, as much as the federal and statewide response is important. Ultimately, it has to be implementable at the local level because that's where people actually live. This is what the coalitions look like. This is just sort of a graphic that represents the diversity of stakeholders at the local level that come together to address this. In Marin County, we have a coalition called RX Safe Marin. You'll hear from April Rivero later, who's from Contra Costa, and she's actively part of their coalition. These are the strategies that have been promoted through the coalitions. This is sort of the consensus within the state of California between the Department of Healthcare Services, Department of Public Health, local coalition leaders as the main domains of evidence-based strategies that you want to be promoting together. The first is to prevent new addictions, right? So we need to stop the bleed, and that remains an important strategy. In fact, because opioids are so ubiquitous, even in prescribing, we are still generating people who are becoming newly addicted to opioids. So we need to make sure that we're addressing that side of the equation through safe prescribing efforts, drug disposal and take back, so making sure that when people have their medicine cabinets unused and unwanted medications, they have safe opportunities to dispose of them, and then working upstream with our youth in terms of educating people about the potential harms so that we're increasing awareness. The next domain is managing chronic pain safely. We recognize that many people who are struggling with opioid addiction and misuse and who are at risk of overdose are actually, as I mentioned, sort of been historically offered these treatments and are on very high doses of opioids that are now viewed as unsafe. And there's an alarming sort of heterogeneity in the way that's approached. Some doctors are like, I'm out. Like, I know that this is unsafe now, and I'm just not going to prescribe these, leaving patients high and dry. Others will say, well, this patient is secure and safe within this regimen. I don't see a problem. I'm going to leave them where they are, and may even continue to increase if they take it from a functional standpoint. There's not a lot of consensus around how we manage this. One thing that's important, though, is that many of these patients are taking medicines for chronic pain, and we do not have good alternatives for the management of that pain. It's not enough to say you can't prescribe opioids. We need to say, and here's something else you can offer these people. That's a huge area that we're working on. Tapering from high doses and limiting unsafe combinations of medicines that contribute to opioid overdose risk, like benzodiazepines, which are sedatives for anxiety and sleep, as well as opioids. Many of the patients, if we look at the data, who actually overdose and die, it's more than just the opioid. There's often combinations of those drugs. Finally, treating addiction, or next is treating addiction. This is one of the most important gaps I think we all recognize in our system, is that we need better opportunities for people who are addicted to opioids to get into the treatment that they deserve and need. There is a remedy. There's a treatment. This is a treatable disorder. That's an important message, and we need to make sure people can get into treatment. Partly, reducing the stigma at the social level, I think, is an important part of that, and that's one of the state strategies. And then finally, for harm reduction, the last is stopping overdose deaths. So recognizing that people are at risk of overdose because of the other determinants. If someone is actually overdosing and you have naloxone on hand, which is the medicine that will reverse the overdose when it occurs, it can be as simple as a nasal spray, you can save that life. So downstream strategies to stop the overdose deaths, including needle exchange and naloxone. So those are the big strategies. I'm just going to quickly go through some of the data behind them. This is for preventing overdose risks. we know that when with 10 days of the initial prescription, you already have about a 15% chance that someone will be taking that medicine a year from now. So this is the idea that when you prescribe for broken ankles, for example, even just a few days of opioids, there's a risk that that person will be taking that opioid 1 year from now. That was not your intent as a prescriber, but that's what happens because of the nature of the medicines. For managing patients who are on very high doses, this describes the way in which there's a very dose-dependent risk of overdose, and that people who are taking, on the lower right there, taking very high doses of opioids on a daily basis are at much higher risk of having an overdose death. Treating, we want to make sure that people are having access to the ongoing treatment, not just a detox approach, but actually a maintenance approach, and that there's data that shows that people who are on maintenance on the lower right-hand side are having much lower risk of overdose deaths than people who are detoxed. Fortunately, on the upper left there, we're seeing that there's increases in the amount of opioids being, buprenorphine being prescribed. All right, and then this is, fentanyl is coming in. And we're seeing, because of fentanyl, we're needing to accelerate our progress around Narcan and naloxone. I'm going to go quickly to this is what our coalition looks like in Marin County. And the idea is obviously we need to bring our superpowers to the table, right? And so you all have a superpower that we need desperately, and it's been really not as present in our response in terms of tech solutions and data. I know I'm out of time. Am I out of time? All right, let me just go through. So at 1 o'clock, we're going to have a conversation about, for those of you who are actually going to be engaging in building data solutions, we'll have a conversation about what are the pain points for local actors. So this is, sort of our appeal at the local level. I asked all the coalitions what they would ask you, right? So I, mentioned that I'm coming down here to talk to you. And these are some of the statements, and I'll offer these at 1 o'clock. These are some of the statements that summarize what the physicians see as their biggest issues, what the patients see as their biggest issues right now, what the coalitions are seeing, pharmacists, policymakers, public health, and law enforcement. And I think these are really important because they're in the words of those who are on the front lines and describe sort of the pain points that we're experiencing. So prescription for today, courage, creativity, and hope. You need to bring a sense of humor and make sure that you bring your superpower. And we can do it. And this is my 7-year-old boy who's reminding us that it's not just for this generation, but it's for the next generation and on the work that we do together today. Thank you.
I mentioned that one of our big prominent funders is the National Institutes of Health, and their interest in this event, National Institute on Drug Abuse, is being able to understand not just their traditional role in public health and medicine, but as this is a complicated crisis, it also intersects with a number of other areas, such as the justice system. So our next speaker is our keynote on behalf of the justice system, coming locally from Orange County. He has a large involvement in the opioid crisis. If you like what he has to say, I'm sure he'd appreciate you voting for him and spreading the word in the coming election. I'd like to welcome our Orange County District Attorney, Tony Rackauckas.
Passed out, right? These folks done passed out on her Facebook with this shit. I don't know. Bro, he might be dead, bro. I don't know, bro. Yeah, I don't know, fool. He might be dead, Jay.
We doctors were wrong in thinking that opioids can't be used long term. They can be and they should be. We used to think they'd stop working, or the patients would become addicts, or they'd be sedated into inactivity. We now find that these medicines are much safer, much more powerful, much more versatile than we used to think, and we feel that they should be used much more liberally for people with all sorts of chronic pain.
Some patients may be afraid of taking opioids because they're perceived as too strong or addictive. But that is far from actual fact. Less than 1% of patients taking opioids actually become addicted.
She making noises. She making noises. Yeah. She's breathing. Come on, baby. Breathing? Yeah, she's trying to. Come on, girl.
Come on, Jay, wake up. Jay, wake up. Look at me. Look at me, Jay. Jay, look at me. Come on. Good morning. I'm Tony Rukakis, Orange County District Attorney, and glad to be invited here to talk a little bit about some of our responses in law enforcement, particularly in the DA's office, with respect to this opioid crisis. That clip that you just saw was from an HBO documentary, This Pill May Kill You. And of course it shows people under the influence of opioids juxtaposed to the advertising that was paid for primarily by Purdue Pharma to advertise the use of opioids and to attempt to convince doctors and other people that it doesn't have the addictive qualities that it actually does have. Generally, the goals of the criminal justice system are to enforce the law, to deter crime and to protect public safety. In the context of this opioid epidemic, we've tried our best in our office to try to approach those goals aggressively and successfully. So we can talk about the front end and the back end, I think, is to make a little bit of sense. So on the front end, we've alleged in our case against Purdue Pharma and other pharmaceutical companies that have increased the supply created by aggressive marketing and drugs for chronic pain conditions. And so with respect to these companies, we've filed an unfair business practices case to try to change the way that drugs are marketed, and also to try to, in my view, to try to require them to spend a good deal more money, or to spend a good deal more money in the treatment of the addiction. So on the back end, what we see, of course, is hundreds of deaths just in our county. And you saw the numbers a little bit ago, national numbers, but in our county we have hundreds of overdose deaths annually, and there's a proliferation of people driving under the influence of opioids, and now, in addition to that, we're seeing a lot of fraud in the addiction treatment area, where people are coming there to seek help. And some of these treatment programs are just helping very little or not at all, but aggressively billing insurance companies to get a lot of money. So we were one of the first, but now there are over 1,500 jurisdictions nationwide to file this case against the manufacturers of opioids, and so that process is growing exponentially. In fact, it's, to be honest with you, it's kind of complicating our prosecution of our case because there's so many plaintiffs. But we have a trial set in June, and so our expectation is to bring Purdue Pharma and a number of these other 4 other pharmaceutical companies to trial. Our complaint alleges that the
origins of the epidemic relate to increases in the availability of the drugs and changes in the way that the drugs were prescribed. And that's the front part of our strategy, sort of preemptive, trying to combat and reduce the supply. The more traditional prosecution that we're involved in to try to combat the crime after the fact is a couple of things. Well, one is the driving under the influence of drugs, and so we've done quite a bit of work now to aggressively go after driving under the influence of drugs. And in that regard, we've gotten some grants. We've developed expertise in our ability to prosecute those cases, and we're teaching other district attorneys' offices in this state and in other states about the procedures for developing the evidence and prosecuting those cases. We've also started on I've started an addiction recovery task force to combat the crime that so many vulnerable people who are addicted are trying to get help, and basically they and the insurance companies are being defrauded. So our prosecution efforts in the drug driving are I mentioned those already. I mean, it's a big issue, is driving under the influence of drugs, and we're prosecuting that on a daily basis. And we've trained prosecutors to specialize in that, or to at least spend much of their specialty in that. And we have them in the branch courts. On a homicide unit, we have a prosecutor in the homicide unit specifically for driving under the influence of drugs, because it causes so many deaths. In 2010, a nationwide study of deadly crashes found that about 47% of drivers who tested positive for drugs had used a prescription drug, most commonly prescription painkillers. Trying to move through this a little bit faster because I know we're behind. So another area that I mentioned quickly was with respect to problems relating to fraud associated with the addiction treatment centers. So the demand for treatment and the lack of regulations in this area has created an environment ripe for fraud, as unscrupulous operators use addicts to enrich themselves through insurance payments. It's also caused a proliferation of unregulated sober living homes spreading throughout our neighborhoods. We filed an action a few weeks ago in which the defendants are accused of misleading those people who desperately are looking for help, promoting a non-FDA approved experimental operation where it's naltrexone implant surgery, where they take this naltrexone and implant it in their, I call them victims, in an experimental, untested type of surgery, and they're claiming that surgery will help these addicts, or people who are addicted to these opioids, to not have the desire to continue to use opioids. There's no evidence for that, but that's their claim. So we brought a case against actually more than one of these companies, and we've also even found and alleged that they use body brokers who are profiting from delivering patients to treatment centers to have these treatments. So we've charged, in this one case against Sober Life USA, we've charged 5 doctors, 4 body brokers, the Sober Life USA owner, and 1 staff member. And this is just one of the many different types of schemes that we've been seeing, in addition to in the addiction treatment realm. We've set up that task force to to work on this. And the task force, the acronym for it is SLIP, Sober Living, Investigation, and Prosecution. And so we're going to do more than just prosecute with it because this involves the need for public awareness very much. And so, so we're working with various stakeholders in the community, and we want to vigorously prosecute, but we want people to know what's happening, and we want other people who are thinking about opening up sober living homes so that they can cash in to understand that this might have legal consequences for them. So we were the first office in the U.S., the first DA's office in the U.S. to file a civil prosecution against the 5 largest manufacturers of prescription opioids for deceptive marketing practices related to the use of drugs for chronic pain relief. That case, or this particular case, is an effort to change or reduce the supply of the epidemic by holding the companies responsible for the considerable costs that municipalities are now routinely incurring relating to opioid addiction. Our complaint was filed in 2014. It alleges that the defendants overstated the benefits and minimized the risks associated with opioid use for chronic pain conditions. What were the messages that were so pervasive to doctors and consumers to change the way that we viewed these drugs? One of the most important messages we've alleged in our case might sound familiar to you, as it's been used to promote other products in the past. You might recall that the tobacco executives used this marketing, they used this to market their product. They all swore that tobacco was not addictive. You saw the clip in the beginning of this presentation where they stated that there was less than a 1% chance of addiction. That's patently false. So we know that's not true. This is another of the marketing messages that we've highlighted in our complaint, that the unbranded, so when we say unbranded marketing, so what we found is that there's been a lot of marketing for indicating to doctors and the public that it's okay to use opioids for chronic pain. Well, we know that it's addictive, and of course they've underestimated or understated the addictive qualities of the opioids, and so they've done a lot of marketing that's not branded. In other words, it's not stated that Purdue Pharma, for example, is paying for this advertisement or paying for that marketing or paying for this doctor to make a presentation in the continuing education arena. And but they know that when they increase the market, just in general, when they increase the market for the use of opioids, it's a big boost to them. And so this. So their marketing includes that it's not addictive, like I just said, but then also that it's better than alternative pain relievers. And when you look into it, there isn't really a lot of evidence to show that it's better for chronic pain relief over time than other over-the-counter pain relievers. Another of the messages that we've alleged to be deceptive in our complaint is that the drugs had abuse deterrent properties to help the doctors feel more comfortable with prescribing them. Those abuse deterrent properties have been greatly exaggerated. How were those messages communicated? One way was via the pharmaceutical sales rep. So the pharmaceutical sales rep they're well-trained, well-paid, and so well known to be attractive and bubbly that references to them have even popped up in our popular culture.
These are some of the hottest girls I've ever seen. And they all work with Tiffany?
Yep.
There can only be one explanation for this. Ted, is Tiffany a pharmaceutical sales rep?
Yeah, how did you know that?
And you never thought to mention that?
In addition to pharmaceutical sales reps, we've alleged in our complaint and found that that a lot of the messaging was done through key opinion leaders. And the key opinion leaders are doctors, tend to be well-known doctors who promote the opioids as a good drug and to be used for chronic pain relief. And they promote these messages, and they appear to be neutral. But what's not known is that they're financially backed by the pharmaceutical companies. So, like I said, much of the advertising is unbranded, and the FDA doesn't regulate or monitor the unbranded drug advertising. And actually, the FDA doesn't really monitor any of the advertising. So, in summary, our prosecution efforts we're trying to target each end of this. We're trying to work against the front end to try to bring the pharmaceutical companies into line with respect to what they're saying and how they're advertising. And I think that we're seeing changes in that already. And we're seeing changes also in the fact that doctors are becoming much less willing to prescribe opioids over time, because this whole myth about they're not addictive is understood to be just that, to be a myth. And we're working strongly against the drug driving and the fraudulent addiction treatment homes, or these sober living homes. So we're pretty active, and we still have our our minds open, and we're looking to see what else we can do, how we can make an impact. But this is a horrible crisis. I mean, this is a terrible epidemic, and when we get to the point like where we are, where more people are dying from opioid overdoses than from traffic accidents, this is a big, huge cause of death in our country, and we just need to do something about it. So, thank you so much.
Our next speaker is also a local speaker from across the street here at UCI. We have the Vice Chair of Research and Academic Affairs from the Department of Emergency Medicine at the University of California, Irvine School of Medicine. He is also a specialist in substance use and the opioid crisis. Please welcome Dr. Bharath Chakravarthy.
Right. We need a doctor to Recess Bay A. We need a doctor to Recess Bay A. Now, I'm an emergency physician. I've been doing this for 10 years. I don't really get excited about too much. My life's pretty exciting, but you develop a level of tolerance. But when my nurses yell that out, and I'm in the doctor's bay, you can see the level of excitement and enthusiasm. Everyone jumps up. Our nurses don't cry wolf. We get out there into Recess Bay, and what do we find? Well, we find someone who is altered. That means they're not their normal selves. They're blue, they're cyanotic, and they're not breathing, they have pinpoint pupils. Now that's a pretty easy diagnosis for us to make, given the setting that I'm in and the training that I've received. But the team gets together and we give them that life-saving medication that you've heard before, naloxone, and they improve. And we see this all the time, unfortunately, in the emergency department. That's my setting. I work there 3 days a week in the ER, and it's unfortunate the number of overdoses that I see. Now, here you see depicted a needle and a syringe, but to be honest with you, this story transcends just illicit drug use. There's a lot of unintentional overdoses, as you well know. We all have heard a little bit about where all of this came from historically, but the bottom line is this is the end result of a number of systematic, personal, professional, and patient-level choices. And as all of these epidemics occur, there's a multifactorial etiology to all of this. But let's talk a little bit about some of the problems, a little bit of what's being done, and some of the barriers that you've all heard about. So I apologize if some of these slides may be redundant, but we'll go over them quickly. Number one, an estimated 1.8 million Americans have opioid use disorder. Okay, that's kind of the common nomenclature that we all talk about in the space of addiction, opioid use disorder. 626,000 of those have heroin-related opioid use disorder, so a good majority of them are prescribed opioids. Estimated cost, ridiculously high. Opioid-related emergency department deaths, and what part of the whole healthcare system is the most expensive? The hospital, right? The emergency department, in hospitalization, the ICU. Now, we don't want that to happen for a number of reasons, but at the patient level, we really don't want them to get to that point. 2.1 million people in the US ages 12 and older have opioid use disorder involving prescription opioids and heroin or both, right? There's a whole concept of the chicken and the egg. Are we priming people for illicit drug use, or are we substituting? It's probably a combination of both, and maybe it doesn't matter so much as long as we recognize that it's complex. We all know that opioid addiction is not just about overdoses. There's a myriad of other issues that occur with them. A lot of other chronic diseases can occur, as well as acute diseases, skin abscesses, endocarditis, hepatitis, you name it, and the years of potential life lost as a public health person. That's what we think about. We have a productive member of society who somehow ends up addicted or in the spectrum of opioid use disorder, who now is no longer functioning on a real level, holding down a job, building relationships in their community and their families, and being a productive member of society. And so we want to get those folks back to that position. We've seen a ridiculous increase in the number of in-hospital stays as well with this whole epidemic. We just heard from Tony Rokakis about opioid addiction and illegal activity and incarceration and how that's all linked together. And again, stressing the need that we can't work in silos. You've heard this probably a number of times. We have to really kind of work in a collaborative atmosphere to tackle this issue together. And that's easier said than done, but that's the issue. You've seen this slide before. I actually borrowed this slide from Matt before, so he gave a talk at UCI maybe 6 months ago or so, and I borrowed this slide from you, and I kind of added a few points. But really, these are some of the things that we think about in that whole space of opioids from a public health perspective, right? We want to prevent. We want to start fewer opioids. We want to have shorter durations. So although we are prescribing less pills, the actual strength of the pills may be more potent. And so we have to be cognizant of that. We want to think about upstream education, both at the patient level, at the primary care provider level, at the specialist level. This is really important. How about managing that whole pain? We don't want to just say no. We want to make sure that we offer out a solution to those who are in this spectrum of tolerance, abuse, addiction, whatever it may be. So alternative therapies, tapering high doses, limiting opioids and sedatives. That's extremely important when we talk about risk, okay? How about treatment? Medication-assisted treatment programs you've heard about. Reducing the stigma. There's a ridiculous amount of stigma out there for all of the teams The stigma really is twofold. One is a societal stigma. Two is a provider stigma to engage in these types of conversations with our patients who we know we're probably overprescribing, who we know that probably has an issue. It's hard, right? We're physicians, we're providers. We don't want to always have a negative conversation with our patients. We want our patients to like us, right? We don't want to argue with our patients. There's a lot of other forces involved, including patient satisfaction scores and whatnot. But the bottom line is, when we became physicians, when we became providers, we took the Hippocratic Oath. The main focus of the Hippocratic Oath is to do no harm, right? So if we just focus on that, and if that patient across from us is, if we think of them as our family member, we hope that we can engage that inner empathy to do the right thing. But that stigma is hard. It's hard to convince physicians to have that difficult conversation with patients. You know, my wife's a pediatrician, and anytime a kid comes with a parent for an earache, there's one thing that they want: antibiotics, right? But we all know 75% of ear infections don't require antibiotics. But that's a hard conversation to have, the antibiotic stewardship. But we're more likely to have that because we don't want to have a discussion with Mr. Johnson or Mrs. Suarez or Mr. Patel, you know, to say, hey, we think you might have an issue and a problem. You know, that conversation is difficult to have, and we're not trained to have those conversations as easily. We need to think about that stigma. We also talked a little bit about stopping the end result, which is deaths, right? We want to keep people alive. We want to keep them, we want to reduce harm, and we want to make sure that we can then have those pool of patients to get them back to a productive, have them converted back to a productive person in society. So these are really, really important. Some of these topics are controversial to the general public, including supervised injection sites. But these are thoughts and ideas that we should discuss and not just sweep away. So thinking about some of the actionable items that many of the coalitions out there in California and beyond that look at as safer prescribing practices, right? So we created this infographic, really cool and wonderful. Great, it's awesome. It gives the data. But if it stays on my shelf or in my computer, what difference does it make, right? So we want to measure the effectiveness, measure the penetrance. Are people using it? Is it making a difference? So evidence-based medicine and data is really important. And there's a lot of confounding in public health data. There's a lot of confounders, but we want to really focus on smart objectives and deliverables. Alternatives, right? We talked about alternatives in treatment. Ibuprofen. I mean, this is my go-to. I go to Costco, get me a double, you know, bag of ibuprofen, and every time I play basketball or tennis and my knees act up, that's what I'm going to. So, you know, resetting that conversation, reinforcing that conversation to our patients, to our providers, I think is really important. You know, there's other alternatives as well for certain chief complaints and disease processes, like trigger point injections. You know, you have low back pain or point trigger pain. You know, trigger point injections, believe it or not, are efficacious, and they do work. What are we injecting in there? You can inject whatever you want. In fact, you don't even need to inject anything. The fact of the matter is, and I don't know how the science works, but actually putting a needle into that spot that hurts the most and just injecting saline water actually is more helpful than prescribing medications. We also spoke a little bit about cannabinoids and CBD, and I think we need more data, right? We need to figure out, does this work? How does it work? Is it alternatives? Is it going to work in conjunction with the medical assistant treatment programs for opioid use disorder or for kind of primary healthcare needs? A lot of data out there, right? You guys are privy to this data during your coding sessions and your hackathon sessions, but a lot of data out there. There's a lot of EMRs out there, right? I will tell you, from an end user perspective, the EMR doesn't work for me. It takes me away from the patients. I want the EMR to work for me. I know that's what you guys are striving for, but the electronic medical record can work for physicians and healthcare institutions. It would be amazing. We talked a little bit about MAT. I won't really belabor the point, but there's a number of different types of MAT, medical assistant treatment programs. primarily focusing on bup or buprenorphine, Suboxone, whatever you want to call it, is what I think can be extremely helpful, and there's some national-wide measures to kind of head in that direction. So a lot of obstacles, right? A lot of obstacles, but we can overcome these obstacles. There's data that people that don't talk to each other with data elements and so on and so forth. But what are the opportunities? I think in these obstacles, there are opportunities. And here's a few opportunities from my perspective that I think may be helpful in some of your projects in bringing it to fruition. So EMR, so patient treatment and screening, how do we identify these high-risk users? And how do we incorporate that in an EMR? There's a number of EMR systems. Can we develop some coding that can go into these EMRs at some sort of national level that then, you know, the end users, hospitals can plug and play if need be, instead of every single institution going into these EMRs and then having their own analysts or programmers program something. So that's one thing. Reminders, automation, and integration. I think integration of data we've spoken about a lot. We have a lot of wonderful speakers here. I think that's extremely important. Although we have aggregate data available to us and we have scientists who are getting aggregate data, what about patient-level data? Do I know that that patient that I saw that has 100 morphine milligram equivalents of morphine and benzodiazepines is over the age of 65, if I actually reduce the number of prescriptions or morphine milligram equivalents for that patient, for those cohorts of patients over time, do I see a reduction in those patients specifically in emergency department visits, hospitalizations, and deaths? That's extremely important for public health folks. Extremely important, surveillance data. Let's talk about mobile health technologies and wearables, a field that's really exciting, whether it's apps, wearables. How do we get early warning systems, the canary in the coal mine? How do we get people to adhere to medical assistant treatment programs or whatever it may be, get to their next appointment, develop a social network of like users who can help each other out? These are really, really interesting opportunities. That's my time. I know it's extremely short. I speak really fast, but I think we're not taking questions, so thank you.
All right, thank you, Dr. Chakravarti. Building on that discussion about stigma and the experience of patients on opioids, our next speaker, coming to us from Riverside University Health System as a research specialist, is Kieran Gill.
Well, thank you, Dr. Young. I'm sorry, I decided to sit all the way at the top so that I had to hurry down here. But as Dr. Young mentioned, my name is Kieran Gill. I'm coming here from Riverside University Health System and from UCLA. I still work with UCLA doing project coordination. So I'm here to talk about the HOPE intervention and behavior change technologies for opioid overdose prevention. So a perk of going after some wonderful speakers is that, as you all have heard in talks earlier today, the opioid crisis has started with the use of prescription pain medication, leading to addiction, abuse, dependence, and the ultimate use of illicit drug use. So we thought to ourselves, in order to address this issue, our team at UCLA decided to go directly to the source. We set up a study where we first interviewed UCLA patients on chronic opioid pain and asked, what do you currently use for opioid addiction? And what do you feel would help you address any of these unmet needs? And the results that we found were, here's some direct quotes, yes, that there are existing support groups, support groups are great, but they aren't necessarily meeting their needs. That they'd go to these support groups, found them to be somewhat superficial, felt a little dogmatic, and there was no relatability to their specific needs. So instead of going to these groups and feeling supported, they would come out sometimes feeling judged. That there's a need for tailored support. That a key to feeling support is to feel specific connections to your group. And sometimes they'd go to these groups and they'd feel like, okay, well, maybe it would be more beneficial if maybe we separated out the people that are using opioids to get high versus those that are using it for pain. And that online communities are needed, that online support groups do allow you to post as little or as much as you need, and it helps you not feel alone because you can go online at any time of the day and you can post if you'd feel like, and you can receive instant feedback, or you just have that opportunity to vent, and sometimes that's all you really need. So we realized that we already have something that could do all of these things, that can meet the need of having support groups, tailoring it to specific populations, and having it be online. We have a study that literally does all of this. It's called our HOPE study, and it helps create communities by bringing people together that have shared backgrounds, connecting members via an online platform, and it's easy to use because it's online. And you're able to discuss barriers to opioid overdose prevention in open discussion, so you can address stigma. So to give you a little bit of background on what the HOPE study is, HOPE stands for Harnessing Online Peer Education. It's a design that's been around for almost 10 years now, and it focuses on online communication as a means to disseminate health education and change people's health behaviors. The reason for doing it online is that there is a shift in communication. You know, there is less face-to-face time. There is less communication going on via phone, email, whatever it may be, that there is this technology takeover, that people are using social media as a means of connecting and in communicating. So how does HOPE work? HOPE works by deciding on a target population, using Facebook as our social media platform to connect people and see if that has a capacity to change people's health behaviors. So how the study is designed, just to give you like a quick little background, recruit some participants. We didn't recruit however it may be. We did it online, and you split the group into an intervention group or control group, actually 2 in each. The intervention group has peer leaders, what we identified as being people who are active community leaders already, and they receive training by UCLA staff on the epidemic of whatever our focus is on, and on how to use social media as a means of disseminating or just communicating in general. And and that's the intervention group, is the group with the peer leaders, versus the control group that does not have those peer leaders. And for our initial HOPE studies, our population was HIV population, and results showed that peer leaders in this virtual community were able to establish community norms by reaching out at both a community level and at an individual level to promote HIV prevention. And we found that those participants would begin to communicate with one another and help spread those norms throughout the community, and ultimately strengthen and ultimately go outside of the community and start to disseminate that education as well. The ultimate results of our HIV study showed that in the intervention groups, they were twice as likely to change their health behaviors than the control groups. So we thought to ourselves, we already have this great design. What we're going to do is apply it to an opioid intervention. And Opioid is actually the name of when this intervention was put forth. Our intervention group renamed themselves, instead of being study group 1, they renamed themselves Opioid. I thought that was very nice and clever. So for the duration, we're going to refer to this study as Opioid. So we created this HOPE study for the opioid intervention, and we recruited UCLA patients on chronic opioid therapy for non-cancer pain through the UCLA medical record patient registry. And the criteria for being a member was that you had to be a UCLA patient prescribed an opioid for non-cancer chronic pain for at least 3 months, and score at least a 9 on the current opioid misuse measure, that COM score you see here, and that they were willing to join an online support group. The peer role models in this study had to fit those exact same criteria, and that they were recommended by a study physician as being somebody who is sociable and effectively managing their own prescription opioids. So we interviewed the study staff and those that's, sort of thrown off, sorry. And those that selected attended 2 4-hour training sessions at UCLA on chronic opioids to get that background epidemic or epidemiology on opioids, as well as receive that information on how to use Facebook as a means to disseminate education and connect with people, and have the etiquette to communicate via an online means. Oh, and again, the intervention, they were either split into 2 groups, an intervention group or control group. Intervention group had those peer role models, whereas the control group did not. So our outcome measures for this study were to see if we could find a reduction in their COM score and their GAD-7 score. And we collected pre-posts of a saliva drug test to see if there was a decrease in polysubstance use and a decrease in their dosage of prescription opioids. There were a total of 51 people who took part in the opioid study, an average age of 44 and a half. Majority were female. They came from a variety of different educational and income backgrounds. Some outcome results. So here we see for the GAD-7, there was a statistically significant difference from being in the intervention group, that their scores decreased significantly versus those that were in the control group. But that the COM scores seemed to, no matter what, being a part of a study seemed to show that their COM scores did change. So being a part of a community was efficient enough to have changed those scores, but that being in an intervention was able to change the GAD-7 scores. So instead, we decided, okay, let's take a closer look at the group engagement statistics. So we found that, here you see at the bottom, the intervention group had a mean of being engaged, a score of 8.2 versus 1.25 in the control group. And we see that the conversation topics varied very much so. That those in the intervention group used social media to discuss their pain, prescription opioid use, coping strategies, places to seek help, alternative therapies for pain, etc. Versus the control group, they were able to express their pain, but they weren't able to get to those conversations and the solutions for the pain. So quickly just going over a couple of examples of what the posts looked like throughout the study. Here in week 1, a control group and the intervention group, they're doing a kind of an equal amount of posting, of introducing themselves, equal quality. Introducing themselves, giving themselves background on why they're here, why they were prescribed opioids, and so on. Whereas in week 4, you see that the control group, they're wondering, like, okay, now that we've introduced ourselves, now what? So it was kind of week 1, introduced, a lull, and then here we're a month later and they don't really know what to do with themselves. Versus the intervention group, they're continuing to talk about current cases of what they're feeling and what's going on. At week 8, we see that there's a difference in the control group. Now they're attempting, it's week 8, attempting to engage people again, attempting to share their stories. And we see that this post was seen by 18 people, liked by 1, and commented by 0. Whereas in the intervention group, you see that here, this post, it's a month premature to the study being finished, and people are worrying about what do we do once the study's over? You know, like, do we get to maintain this relationship? They don't want to lose this group. And this post was seen by 16 people, liked by 4, commented by 9. Then week 12, the end of the study, you still see the control group trying to make posts. We see, like, when people aren't responding to written text, they'll post pictures to try to get people, like, to quickly see see whatever they're writing. And this time it was seen by 8 people, so half the number of people, liked by 2 and commented by 0, whereas intervention group continuing to talk about their pain, and seen by 16, liked by 2, commented by 5. So quickly, just to go over the rest of this, I know we're short on time. the reflection is the control group, they did begin to open up and introduce themselves, attempted to engage, and continue to attempt to build this community, whereas this picture here was a direct post from the intervention group. Somebody had posted saying that, I found my people, I found this group, I love being here. And some more results that we've seen is that you really see a transfer in the role from these peer role models to the participants, where now they were taking on the role of peer leaders, and they were the ones making posts saying, oh my gosh, like I read your story, it really inspired me, or hey, like this is a situation, how would you relate to this? Taking on those peer role models roles. And a couple of posts about them staying connected post the study. The study ended in October of 2016. A month later, Thanksgiving came around, people are still posting in there. New Year's came around, people are posting there, starting to refer to each other as friends, Facebook friends, and this bottom saying, like, love to you all. So some intervention quotes to kind of show like whether this intervention was successful in meeting those 3 needs that I had mentioned in the beginning. And it said, like some things highlighted here, I personally was more comfortable telling my story in writing. And a lot of these stories that I was able to read in these forums mirrored my own stories, and I was able to learn a lot from them. That once you start to share, it really does help. And in this quote on the bottom here, it said that in real life that he didn't have people who cared to listen, and that the few that did, they didn't understand. So it was really valuable for him to be a part of this community and share with people who were in the same boat as him. And this one at the top here, I really like to point it out, where it said that he canceled his plans for that evening and stayed glued to his monitor, and was brought to tears because for the first time in 27 years of life dominated by pain, someone got exactly how he felt. And that everyone's story relates to something unique that only those like us can truly comprehend. We're all at different pitfalls and obstacles, but that only adds to the benefit of learning from one another. So in conclusion, what this all shows here is that results are promising, that online communities are useful, and the use of technology can create connection. That there is room for improvement and innovation, that hope, all caps, can provide hope, lowercase, for the future. So thank you.
Okay, and our next speaker, as we've talked about now, this epidemic intersects a number of different areas. We've talked about public health, talked about law. Our next speaker comes to us in the area of law enforcement. Coming from the state capitol in Sacramento, please welcome Captain Helena Williams. She is the captain at the California Highway Patrol, as well as the head of the impaired driving unit for the CHP. You're welcome.
Good morning. As you can see, I have a couple of different challenges. Number one being vertically challenged, so you're gonna have a hard time seeing me over all this. Number two, as a cop, I like to move. And being stationary here, I like being a moving target, not one that's just stationary. So forgive me if I kind of move around a little bit. I'm a 25-year veteran with the California Highway Patrol. And DUID, so driving while impaired, has been my passion since I came on the patrol. And now, fast forward to where we are now, it's such an epidemic because there's so many different substances that are available to our communities that make people feel good. So if they make you feel good, the chances for you to become addicted and to abuse that substance increases. Hence, with the passage of Prop 64, the legalization of cannabis in the state of California. What the Highway Patrol did was they actually created an impaired driving section solely dedicated to impaired driving, not only of alcohol, but all different drug categories. So extremely important that the Highway Patrol is now dedicated not only a commander, but a whole entire staff dedicated to this problem. What are our biggest hurdles in these cases? Is community perceptions, okay, officer training, how drugs metabolize, and accurate data. As I've heard just sitting in this room just for about an hour now, that seems to be the very common theme, is data. And in our arena, in law enforcement, there's lack of data to support some of the directions in which law enforcement wants to go. And the reason being is because of the statutory law, the way that the law is put together. So if you look at DUI, you have a variety of different sections of law that you can be charged with. Up until recently, the law was the A section. So if you're driving under the influence of alcohol and/or a drug, and B, 0.08 blood alcohol content or above. So we haven't been able to capture really the problem of DUID because the A section puts it all together. It doesn't separate all the different drug categories. Okay, so that's extremely challenging for law enforcement. Officer training. There's 80,000 law enforcement professionals in the state of California. And I'll get to some training that we give to law enforcement, but when we look at the numbers, it's just a little bit less than 10%. And then how drugs metabolize. You all in this room are pretty well-versed in how drugs metabolize. When we even just talk about cannabis, metabolizes totally different than alcohol. Alcohol loves water, cannabis loves fat. So of course it's going to metabolize a lot different in the human body. How many of you have heard this? Okay, I drive better high. Not so, right, when we have incidents like this. And this person was 5 nanograms of cannabis, or delta-9 THC, and a little bit of alcohol. And look at the devastation. Okay, and these are people who are traveling among us on the highways. When we look at some numbers statistically, about 43% of people who have been tested, who have been involved in a fatal collision, had 1 or more drugs on board. So how many of you drove here today? Okay, you drive on the freeway. Usually we probably are driving in the number 2 lane, which is the middle lane, because we don't want to be in the fast lane because you don't want to see people like me, right? Okay, so you drive in the most safe lane. Well, think about it. You have someone in front of you, someone behind you, and left to right. You have a total of 4 people around your vehicle. Now look at 43%. You're bright. What does that mean to you? Does that scare you? Yes, absolutely scares me because I have family, I have friends, I have coworkers, members of my community that I serve, and they're traveling the same roadways with people who are possibly impaired. 43% is pretty high.
Gary Tugman talked with some addicts walking the streets. We want to warn you, this may be tough to watch, but we think it's important to see how the opioid epidemic is unfolding in the U.S. Here's Gary's report.
To most people, this is a neighborhood south of downtown Boston. To others, it's a living hell.
I'm a junkie. I've been shooting heroin for 16 years. I'm homeless. I live on the sidewalk. And this is my life.
You know, I didn't grow up thinking I was going to be a heroin addict. Like, this isn't exactly what I want to be. Like,
what are your hopes and dreams?
To get sober, to have a family. I, at one point, thought I was going to, and I lost the love of my life. We both overdosed, and when I woke up, he was dead.
Billy is 31 years old. He has a 5-year-old son. He wants to be a tattoo artist someday. But even while we talked, he was looking for a vein.
Is it possible for you to stop shooting the heroin while we talk?
If I had gotten it in me, it would be, but
that's what I'm wondering, like you feel such a strong urge that you can't stop while we talk?
Yeah. There's nothing that would stop me. And that's how bad it gets.
Megan also lives on the streets and the sidewalks.
You're about to reach your 30th birthday. And how long have you been addicted to heroin?
Since 19.
And how did you start the first time?
It was pills, then pills became expensive, hard to get, and heroin was just extremely easy to get and a lot cheaper.
Like Megan, the gateway to heroin for Billy was also pain pills. He was 13 years old when he started.
I was already using prescription pills. I liked the way it felt. I found out heroin was cheaper than the pills, and it was more intense, so I began sniffing heroin, and then I found out shooting it was the next step from there, and I would save money, and went right to shooting it. The first time I shot it, I fell in love with it. It was the only way I can explain it is like I met God.
Billy and Megan are joined in their opioid devotion with scores of other people who gather on the street that happens to be near a hospital, methadone clinics, and shelters. People who want to help. 40 miles up the road in the small city of Gloucester, Massachusetts, police will not arrest you if you come to the police station with opioids looking for help. The strategy of help, not handcuffs, started here and spread throughout the country. But after a much publicized and encouraging start, the police chief here is facing a stark reality. Things are not getting better.
We've seen an increase in fentanyl. Fentanyl is a drug that is 50 to 100 times stronger than heroin.
Like heroin, fentanyl is an opioid. Even a tiny dose of it can be lethal. Craig uses fentanyl. Like everyone we met on the street, he wants to stop, but says he can't.
I'm addicted to opiates.
So what do you do here in the street? What kind of opiates?
The thing is, all the opiates right now is fentanyl. So everybody's dying.
It's about to start pouring here in Boston. These people who can't live without their pills and their needles will be sleeping in dirt that will turn into mud.
Are you afraid you're going to die from this?
I know I'm going to die from this.
Are you afraid you're going to die from this?
Not really afraid, and honestly, sometimes it just seems easier.
How does that make you feel? Okay? It's challenging just by listening to what they said. Started at a very young age. One was 13, one was 19. And what did they start with? Pills. Okay, and then just in this little small snippet of video, we saw the progression from addiction to abuse and where they're at now. So the reason why we're all here is we really need to look at a multifaceted approach to this problem. The demographics surrounding this crisis is vast, right? You have middle America, you have businessmen, women, academia, it's all across the board that are using and abusing opioids. And this is what we're faced with. Okay, there are different other drug categories that are used in combination with opioids as well. But when we look at Future here, okay, he has a song that he raps about Molly and Percocets. Okay, so it's in our mainstream culture. It's this acceptance of being able to use and abuse whatever substance that you want. And that's why we're here today, is now we're facing, if you will, we're reaping, what we just sowed. Okay, so until we can take a stand and say this is unacceptable and put resources in place to help with the crisis and the epidemic surrounding all drug use, we're going to keep seeing it being mainstream. Okay, this was in the Midwest. Law enforcement came across this vehicle, and there's a child in the back. Okay, this is my reality as a law enforcement professional. This is what I see. So when people get to this point, this is what I see. And the public safety hazard to me is exposure, not only to hypodermic needles, abscess, other diseases, but also the exposure emotionally. Who wants to deal with that, right? So when we look at a solve for this, we need to look at all the different people who are involved in the public safety sector and come up with real solutions that help everybody. Okay, just the numbers. I heard someone had a different number earlier. Okay, so over half of our opioid-related deaths had fentanyl. Okay, different drug categories. They use in combination. Outreach. Okay, we got to start somewhere, right? If we have 13 and 19-year-olds, where are we going to get the most impact? We got to go where they are. Community-based programs, how to teach, how to educate our youth on the abuse and use of these drugs. Okay, Highway Patrol officers, they are not only trained in the academy, but they had advanced training. By the time they are done with this training, they have over 156 hours of training in drug symptomology and alcohol abuse. We train prosecutors, our judicial professionals, a variety of different disciplines, health services. We're involved with court referral therapists. So we need to teach them about drug symptomology and how to recognize it and how to resource. Just the DRE training, the drug recognition evaluator training, is 72 hours. Then they go into the field and they do hands-on practicals, similar to like clinicals. 32 hours of training, and they evaluate individuals who are actually under the influence of a variety of different drugs, including fentanyl and opiates and heroin and morphine. Okay, prosecution is all about training and outreach. We want to ensure that our prosecutors have relevant and important information so they can appropriately try their cases. I already talked about this earlier. We established an impaired driving section solely dedicated to this issue, and also the issuance of grants to research entities, nonprofits, law enforcement, and other government entities. And we are also working with the University of San Diego on their marijuana and driving study. Okay, current efforts, training officers. Okay, the ARIDE training, which is Advanced Roadside Intoxication Detection Enforcement, we've trained all Highway Patrol rank and file as of last year. And in the same course, we've trained about 7,000 other law enforcement officers. So that number that I had out there earlier, 80,000 law enforcement professionals, we've only barely scratched the surface. Emerging technology, oral fluid saliva testing, roadside. Highway Patrol right now, we're piloting a program looking at this device to give to the officers roadside to help them further detect the abuse of 6 different drug categories. Okay, we have a task force as well. These are all our stakeholders. As you can see, it is a multifaceted approach to DUID issues. Their goal is to establish best practices, look at technology, as well as introduce possibly new laws to further assist with this epidemic. Some more numbers, this is what we talked about earlier. 43% of drivers that were tested had one or more drugs within their system. Oregon and Colorado and Washington, they are seeing the same significant increase, and they're 3 years into the legalization of cannabis alone. Okay, in closing, this is my contact information. If you're interested in furthering training or you want me to bring training to you, I can do that as well. I see there's a question in the back.
Yeah, can I just ask one question? I saw you had methadone up there on the substances for opioids. Have you guys found any embezzlement of much from the clinics? I know there's some concern that embezzlement occurs, and I think mostly overstated, especially with the liquid, but have you seen that being used off the market kind of as a drug of choice?
Where we see it is in combination. Usually you'll have someone who will use methadone, they'll go to a methadone clinic, they will either divert by bringing it out to the street and divert it by selling it, or they'll use it in combination with an illicit drug to keep that high at a higher level for a longer period of time.
Okay, so are they mixing it then, or is it the powdered form or the liquid form that you're ever finding on the street?
Both.
You do find both?
We do find both, yes. Any other questions? Okay, thank you for your time.
Hey everyone, we're going to take about a 5-minute break and we'll come back at 10:45 to get started with the next presentation.
back on track. All right, welcome back, everyone, from our short break. We've made up time, and we're now back up. We're back on track with our schedule. Our next speaker, as we now shift topics to implementation science as well, and how do we, now having the context behind the problems, how do we understand how to implement solutions along with the barriers and study of how to implement through implementation science. Our next speaker is a senior research scientist at Kaiser Permanente, Southern California, Department of Research and Evaluation, and is an expert in implementation science. Please welcome Dr. Brian Mittman.
Thank you. So I too have the advantage of speaking relatively well into the course of the day with no need to talk at all about background or motivation or even about the nature of the solutions that we hope you will all develop over the course of the next couple of days, but instead to focus on the implementation challenge and to discuss in a way that in some ways provides a bit of the academic framing and background for some of the comments that Drs. Willis and Chakravarty both shared. So the motivation for the work that I do for the implementation science field, as well as for the implementation work that will, we hope, follow the solutions that you develop, is captured by this quote. Any of you who've seen any of the National Academy of Medicine reports are familiar with this, but it basically points out the idea that having innovative solutions is not enough. We need to apply them, the societal benefits of those innovations. And this is true of all forms of innovation and intervention development within the health-related fields and other fields as well. And that's really the issue that I'd like to focus on. And I'll say that much of the implementation work follows the completion of the innovations, their development, and demonstrating their value. But we have to keep in mind the concept of designed for dissemination, which actually should be designed for implementation, but pointing out that during the development of those innovative solutions, looking down the road, thinking ahead to likely implementation challenges, and adjusting the design and the features of the solutions that you develop is the most appropriate time to begin to think about the implementation barriers, not only at the end when those solutions are ready for implementation. So the large boulder being pushed up the hill is in some ways the best way to think about the implementation challenge. We have a number of decades of research in implementation science that tells us many things about the challenges of implementing these solutions, especially when they are health-related. We know that for the most part, the behaviors of our health professionals, but also regulatory agencies and organizations and consumers have a high degree of inertia. They're relatively slow to change. There are the occasional exceptions of neat technological solutions that oftentimes are actually implemented too early before they've been proven to be effective. But for the most part, we're dealing with a highly conservative sector of our economy and society. We know that the problems and the solutions are highly heterogeneous. They tend to be very different across different communities and institutions, as well as vary across time. We know that the barriers that we need to overcome occur at multiple levels. And as a result of all of this complexity and heterogeneity, simple solutions are never adequate. Oftentimes they tend to be necessary but not sufficient, and education is perhaps the best example. We need to educate consumers, health professionals, organizations, but simply educating them about the value of a new solution does not even begin to overcome the many challenges and barriers to the appropriate adoption and use of that solution. So there are a number of reasons for this clinical inertia or this conservatism. I won't talk about them, but you've heard some of them. But basically, again, the idea is to think about multiple barriers, multiple challenges. And in some ways, the picture of the boulder It doesn't really fully capture the nature of the problem. I think if you imagine a set of ropes and bars and chains that are holding that boulder in place, that's really what we're up against. And typically the solutions that we deploy are the equivalent of removing one or two of those ropes or bars and chains. And the boulder itself is not going to move until we release all of those factors. So this is one of the key academic frameworks that, again, captures some of the ideas and points that Drs. Willis and Chakravarty had made. Basically, the idea that we have multiple levels that we need to be concerned about. And again, as you think not only about the eventual implementation of solutions, but their design and their characteristics, thinking about the likelihood that each of these different groups of stakeholders and each of these different levels are likely to find those solutions acceptable, valuable, feasible is what we all need to keep in mind throughout the whole process of developing and implementing innovative solutions to societal problems. The very last bullet on this slide is important. 1950s medicine is what we often refer to as the idea that physicians were able to basically do what they wanted, and that the locus of efforts to change practices and to facilitate the adoption of innovative solutions could focus only on physicians. That's, of course, no longer the case. We now have a very broad spectrum of complicated regulations, fiscal barriers, organizational policies. Physicians within the Department of Veterans Affairs, Kaiser, have relatively little autonomy. They do, but relatively speaking, little autonomy over the kinds of care that they provide and the kinds of solutions that they're able to deliver. All of the organizational factors and others represent important influences. So again, thinking about the onion model as it's sometimes described, and thinking about the multiple levels of influence and constraints and factors is the key theme here. So as we try to both study implementation, but also in the policy and practice domain, overcome implementation barriers, the basic idea oftentimes is too little, too late. Basically, we, as I said earlier, essentially release one or two of the ropes and chains. We provide education, oftentimes we provide reminders, we address consumer barriers, but we tend not to recognize, or even if we do recognize, not to have the ability to overcome the multitudes of other barriers that are constraining the practices that we wish to implement, that are keeping us from eliminating the barriers to adoption of effective solutions. So the approach that I like to take in thinking about implementation, again, both for policy and practice audiences as well as researchers, is to think about a checklist of conditions. And when we have supportive conditions in these 8 different domains, implementation, adoption, delivery of innovative solutions is more likely. And I'll spend just a minute or so on each of these going through the list. We know, of course, to begin with, that solutions are not likely to be implemented and adopted if they're not effective, if they're not valuable. So having a good idea is the place that we start. But not all good ideas are created equal. And again, this is especially true in the health-related field. When we talk about implementing the results of large studies, the so-called healthy white male studies that show that a drug or a solution is effective for a limited subset of patients, or in our case, that a solution is effective in certain kinds of communities with high socioeconomic status and lots of supportive resources, those solutions are not necessarily feasible and certainly not necessarily valuable and effective in other kinds of settings. So thinking not only about the need for evidence, but about the right kind of evidence that has demonstrated to be valuable and relevant and applicable to a broad range of settings is one of our key challenges. Condition number 2, again, necessary but not sufficient. We know that we need clinicians, patients, regulatory officials, organizational leaders to understand what to do, to have the knowledge and skill is necessary, but by no means sufficient. In the health-related field, as well as in other professional fields, the literature, theories, ideas from the field called the sociology of the professions is critically important. Physicians often deal with a great deal of uncertainty, and there may be 4 or 5 alternative solutions, and oftentimes the solution that they prefer is not the one that has the greatest amount of evidence, but instead the one that has the greatest amount of professional acceptance. We talk about professional norms, norms within the professional community. So focusing on those norms and using peer influence strategies and others as a way of modifying and influencing professional norms in addition to knowledge, education, and skill is one of the key items on this list of necessary but not sufficient conditions. Physicians, other health professionals, all of us go to work each day with a number of different goals and a number of different opportunities for us to do better. I suppose we can think about the saying, the squeaky wheel gets the grease. Within systems like VA, Kaiser, and many others, it's the practices that are measured and monitored and for which senior leadership and external stakeholders and others place a great deal of importance, where they tend to focus their attention. Those are the practices that tend to get the attention and the attention allocation on the part of the professionals. So we need to make sure that senior leaders and external stakeholders who are considered to be important and influential are pulling in our direction, that they expect to see improvements in pain-related practices. They expect to see implementation of these solutions, and these problems are a priority relative to all of the other opportunities that professionals have to improve care. Consumer acceptance is critically important. It's not enough in the case of medical care and health care for physicians to know what to do. Oftentimes we like to say that no amount of beating the physicians over the head with education and financial incentives and reminders to prescribe the right medicines or to encourage their patients to adopt healthy behaviors. None of that is likely to be enough if the patients themselves are resistant. So focusing on consumers and what we need to do in order to influence consumers and encourage them to be accepting of innovative solutions is part of the struggle, and again, another important item on our list. We often find with physicians in particular that presenting them with a set of recommendations, with a set of innovative solutions, with a set of protocols and guidelines for practicing in order to achieve good outcomes is often viewed as enough. And we often see physicians nodding and saying, yes, I'm aware of those recommendations, I prescribe that medication, I use that solution, until we show those physicians that they're actually not prescribing that medication as appropriate, that the small number of exceptions that they think exist, where my patients are different, or for most patients this is appropriate, but it's not appropriate for mine, we need to provide actual data. And there's a number of, we have a number of solutions and specific methods that we often label audit and feedback and performance monitoring and feedback that allow us to provide the health professionals, the agencies, with the hard data to show them that they are practicing in a way that represents not optimal quality, that there are significant quality gaps or implementation gaps. So again, another item on the list of conditions. Condition number 7, again, is especially important in the healthcare field and others where we have very complicated delivery systems, where it's not just a matter of telling physicians to prescribe A instead of B, but instead changing the entire spectrum of influences. We need to know what it is that is posing and representing the key barrier, or the key barriers more often than not. We need to understand something about why, in the case of some work we're doing at Kaiser, only half of our patients in many parts of Southern California are receiving HPV vaccinations, our 11 and 13-year-olds. Oftentimes it's because the physicians are not being active enough in prescribing, or the nurses make comments about how the vaccine is maybe not so necessary, and other minor comments that actually have significant influence. In other cases, the physicians and nurses are very proactive in promoting vaccination. It's the patients and their parents and their friends and family and other community members who represent the resistance. So the point here is that gaps in the implementation and adoption of effective, innovative practices are not all created equal, that different gaps have different causes. And until we can diagnose the root causes of those gaps, we can't begin to develop and eventually deploy effective solutions. And then finally, logistical arrangements. Again, oftentimes physicians, health system leaders, patients, nurses, others know what to do. They would like to do the right thing. They just don't have the time or the space or the financial reimbursement. So developing innovative solutions to allow for the efficient, feasible, effective delivery of innovative solutions is, again, one of the key items on the list. So let me begin, let me end rather with just one simple slide that in some ways tries to capture this checklist, which again is applicable to the post-solution implementation efforts, but something that ideally you would each keep in mind as you're developing the solution. We know we need to have demonstrated value, and that value of the innovative solutions has to be viewed as relevant and acceptable to the target audiences. We know that we need to understand why that innovative solution is not being delivered, or what the likely barriers are to its delivery. The staff training, the clinician training, the patient training, education, those are all necessary. The monitoring, the pressure from external stakeholders is critically important. Patients are an important part of this in any health-related area. In the logistical issues. And again, as you've heard earlier in the day from multiple speakers, we need not just simple solutions that we will educate clinicians and patients. We need the equivalent of multi-level, multi-stakeholder campaigns that will address all of the barriers, that will bring together all of the stakeholder groups, and eventually hope that we can implement the solutions that we hope to see from your work. So thank you.
Our next speaker is a professor of computer science and engineering at the University of California, Riverside. Please welcome Professor Vagelis Ristidis.
Where are the slides? Oh, here. Okay, so I'm a professor in computer science and also a member of the UCIPT. So I will talk a little about the work we are doing at the Institute. So I would say that there are kind of two types of work we're doing. One is we're building tools to help others in analyzing and data and predicting trends. And the other is we're doing studies in particular applications like opioid, HIV, suicide, and so on. So this is an example of a study that some members of the Institute did, where they analyzed Google Trends queries, and they saw that how they correlate with actual cases of opioid-related hospital visits. And this is another example of this tool that on the right you see a visualization tool that people at the Institute created to visualize the frequency of different things on the map, like for instance could be how many times people mention the word opioid on Twitter, or can be anything else. So this is an example of a tool that can be used for many applications, whereas the previous slide was an example of a specific study on one domain. So I will go a little more in detail on one specific study that I have been involved with, which is studying what people are discussing on online social media related to health, and some of the findings are also relevant to opioid, but you know, in general, it's like more general than that. It's about what people like. What are the health concerns people discuss, and this can give us an idea of what we can learn by just analyzing what people already discuss on the internet. So doing that has many challenges. First of all, is that people write in free form, so it's hard to kind of identify what are the concepts, diseases, symptoms they talk about, because there are many different ways to express the same thing. Also, as you know, people use abbreviations, they use slang, typos, irony, jokes, and also another challenge that we have been specifically putting a lot of effort is that Many of the user profiles don't have any information except the login name, so people just can create some random name. We don't know if they're male, female, how old they are, where they live, and so on. So this is kind of the workflow of the study. So first we collect data from two types of sources. The Twitter and Google Plus represent, let's say, the general social media, whereas then we have health-specific social media, drugs.com, Daily Strength, WebMD, vitals.com, healthgrades.com. So for each of these sources, we have to create specialized crawlers that collect the data and then bring them to some common format, load them to the database. And then after we load everything and we put them in some common format, we do several types of analysis. The first type is we do a demographic analysis of the people who are posting. Sorry for the font, I messed up a little this slide. So it's too big font. So like gender, ethnicity, writing level, and so on. And then we do some content analysis, like what is the sentiment, what are the topics that people talk about, some network analysis, which I will not go into detail. And then we extract some conclusions, as I will show later. So I already mentioned, so some of the sources make it easy to extract data because they have a programming interface. But even if they have, they typically have rate limits on how much data you can get. Some of the sources are harder to collect data from because they either don't care for people to get their data, or they don't want people to get their data. So for these sources, we have to write specialized programs, which we call crawlers, to collect the data. And this is some statistics on how much data we collected from different sources. So I'll put them in three categories. The green is the general purpose social media. The blue is drugs, like general drug-related forums, and the yellow is health discussion forums, more general. And these are the different demographics that we try to get from the users that post on these forums. So you have age, gender, ethnicity, location, and writing level. Some of these attributes are already available in some sources. Some of them we try to guess or estimate using classifiers. For instance, the gender we can estimate from the first name for some of the users. Let's say if you're called Maria, you know it's female. For some other, like most likely, for some other names, maybe it's more challenging. And also another example is for ethnicity, we use the last name and we use census the data to see which names we can say with high confidence if they're Hispanic or they're black or something else. So here I have some details on these classifiers that we use to identify the demographics. I will not go into much detail. And then for writing level, we use we modified existing writing level estimators, which has roughly has to do with how long sentences you use, how long words you use. But we had to modify them because many times in social media, people do not use periods. They just like go on. And this doesn't mean that they're intellectuals, but it means that they don't know how to write. So it's kind of the opposite from what this scale was meant to do. So we had to modify it. And then we used several methods for sentiment analysis, and also to extract medical terms, we used NIH's MetaMap, which is a tool that the NIH has built to extract symptoms, disorders, and so on from free text. And again, we had to do some changes because this was made for medical records, whereas we're using it for social media, and the writing style is very different. So I have a few tables with results. So the main goal here is to see what are the topics that different demographics are more interested in. So across different media. So I try to put like in boldface the words that may be more relevant to opioid topics, even though, as I said, this is general health for every health topic. So, for instance, you see that, let's say, in Twitter, male users talk about AIDS, marijuana, and so on. Female users talk about migraines, eczema, and so on. Now, there are some interesting findings for age. So we see that users like up to 17 years old mostly talk about ADHD, 18 to 34 pregnancy, 35 to 44 multiple sclerosis, 45 to 64 addictive behaviors, which are more relevant to what we're discussing here. And also from 65 and above, chronic diseases. By ethnicity, we were able to, I would say we have less confidence because it is we had less amount of data that we were able to accurately identify the ethnicity of the author, and we could only do it on Twitter and Google+. The reason is that they are the one that have last names, and we need last name to estimate the ethnicity. Because if you go to the other forums, they don't typically have last names. So here we see that, for instance, white users talk about mental disorders, marijuana abuse, and Hispanic users also talk about this and suicide, whereas Asians talk about other health problems. Also here, based on the location, as you see, in the West U.S., we see more discussion about addictive behaviors and marijuana and so on, whereas in the Midwest, there is some discussion, but also a lot of discussion about weight problems and so on. Limitations of using online social media in general is that people who use online social media select to use online social media, so these are not representative of the whole population. So my time is almost up. So last thing I wanted to mention is that we have another tool we have been building is the Crowd Tagger tool, which is a tool to allow researchers to collaboratively label posts so that then they can build classifiers and be able to label more data. So if anybody is interested to use this tool, they can go to this website and ask for an account, and we'll provide one. And then as a final conclusion is that many times the more useful sources, which in my opinion in this case are the online forums and not so much Twitter and Google+, are the ones where it's harder to get accurate demographic information, whereas in, let's say, Twitter and Google+, you have more information about the users, let's say, if they're male or female, but the people do not really have too useful information because they are afraid because people know who they are. So that's it.
Next, we're going to hear a personal story from April Rivera. She's the founder and executive director of the National Coalition Against Prescription Drug Abuse. Please welcome April Rivera.
Hello, I'm really pleased to be able to be with you today. I think I bring a little bit different perspective of the opioid crisis, and I do see it as a crisis. I've been in this space working for the last 8 years to do what I can to educate community members, that's our #1 mission, about the dangers of prescription drugs, to drive down the demand curve for opioids in particular, because people understand that they can become addicted and they could potentially die from it. So my target groups, as you can see, there's really nobody that's not a possible target for me. Yesterday I traveled all the way from Connecticut, and guess what? The person sitting next to me had quite the, we had quite the conversation. So I have found that it's possible, even in an informal way, to communicate information that I think can stimulate maybe an interest in learning more and to potentially save lives, and that's what the point of this is. We also do some policy change work, mostly at the county and the state levels, although I have worked on that at the federal level as well, and along with legislative advocacy. In addition to the organization I founded, and it is a 501c nonprofit organization, the National Coalition Against Prescription Drug Abuse, I also am affiliated with a number of other organizations or coalitions in particular, so you can see a good listing of them here. The ones that I want to call out probably the most would be the Contra Costa County Meds Coalition. That's a coalition that is in my county, Northern California, Contra Costa County. I founded and I chair that coalition. We've been in operation for about 6 years, probably 7. So the other one I want to call out is the Fed Up Coalition. I was actually in Washington, D.C. this past weekend, and the Fed Up Coalition works at a federal level to drive federal action. So we're after the FDA, we're after the president, wherever we can, influence financial, I shouldn't say financial, funding that would come down to our states, then down to the local level to make a difference, primarily in treatment, but also in prevention. So moving forward, why am I in this space? It is because of a personal tragedy in our family. This is my beautiful son, Joey Rivero, who was a college student about to graduate from Arizona State University, one day away from coming home for what would have been his last winter break, when we got the news that he had been found in his off-campus apartment where he lived with his 2 roommates, fellow fraternity brothers of his. 9 days before Joey's death, from what it ended up being, we found out an opioid overdose that was in combination with benzodiazepine, Xanax, and a little bit of alcohol. He'd been to a doctor just 9 days before that, and he had been prescribed medications that he should never have received. That doctor is now serving 30 years to life in prison, Dr. Lee Seng, who some of you may have some awareness of, for prescribing not just to Joey, and the prescribing led to his death, but 2 other young men, and then there were 5 other patients of hers that were part of the trial that happened about 6 years after Joey died that resulted in closure for our family in that regard. So Joey is gone, and I really feel that my work is really in his memory, of course, and Joey was a wonderful kid. There was absolutely no indication of trouble at all. We'd seen him just 3 weeks before when he came home for Thanksgiving break, and what we heard from him was that his 2 roommates had a big pill problem. They weren't paying the rent, they weren't paying for any other expenses, and he was really kind of like, what do? I don't know what I should do here. I've talked to him, they won't come to the table with the money. They need to pay for their share of this apartment. His solution was to go to this doctor when he just happened to run into a couple of guys that were headed there who were seeing the doctor every 30 days for a prescription. It was his easy out. Go back to the university, where I later, of course, learned pill abuse and use was rampant. Joey was the first of 9 students in the course of the year. He was the first of 9 students that either died there at that university of an overdose or a suicide, and one of those suicides was one of his roommates. So I'm going to play a quick video for you. This is something that high school students in our area put together for us, and it really, I think, reflects what we're dealing with here. This is our family's life. This is Joey's life.
Hello, I'm April Rivero.
I would like to introduce you to my son, Joseph John Romero III, fondly known as Joey. Joey was born on March 9, 1988, into a family that simply couldn't wait for him to arrive. Despite the 14-year age difference between Joey and his older brother, the two grew very close during the years, and his dad and I simply adored him from the moment he was born. Joey loved sports right from the start, and he was highly competitive. While soccer was his primary sport through 7th grade, football became his passion, and he was a starter throughout his high school football career. Our family loves the outdoors, and Joey's dad and I have great memories of the vacations we took with Joey in Alaska, the Canadian Rockies, and various other national parks. Joey was a good student, and I would say his favorite subjects were history and English. He was extremely creative, and we were constantly amazed by the creative art, video, and writing projects he shared with us. Joey was an extremely popular young man. He had such an engaging personality, and he lit up every room he entered. Joey loved to laugh, and he was known for his jokes, daring spirit, and huge hugs. He was also non-judgmental and caring, and many considered him their best friend. Joey began attending Arizona State University the fall after high school graduation. He had no problem adapting to college life. He joined a fraternity and had tons of new friends by the end of his first semester. Joey was looking forward to graduation and starting a new career in just 5 months when tragedy struck. On December 18, 2009, Joey died from an accidental overdose of prescribed medications he had mixed with alcohol during a college party. Instead of returning home for Christmas, Joey arrived from Arizona in a casket. We buried him the day after Christmas, with hundreds of his family and friends mourning his loss. The death of our beautiful son has completely shattered the lives of everyone who knew him. Knowing Joey's death was completely avoidable has made it that much harder for us to deal with. This is the doctor who I mentioned earlier has a lot of time that she'll be spending in prison because of her actions. The young man here in the middle is the other young man that is gone from this world, John, and second worst day of my life when we learned that he was no longer with us. This problem is so personal. For every single individual like Joey that passes away, I see the impact, the circle of impact around them. And Dr. Willis, I think it was you that said we've lost 72,000 people in 2017. Take that number and multiply it times even 100 people, friends, family, neighbors, whomever, teachers. The impact is enormous. People are dying every single day, and we've got to do something. We have a major issue, as everyone stated. I won't go through these numbers because you've seen most of it already, but California deaths, we've had a significant number of people lost here, as you can see. But I go to this slide, and I think this is a really important one. These two young men right here are brothers. These two young men here are brothers. I now know families that have lost 3 children to an overdose death. Every single one of these overdoses was avoidable. It didn't have to happen. I know every single one of these, I have 650 photos, and that's just a small fraction of how many we've lost in this world. There are no boundaries, literally. I often talk to parents, and they'll say, oh, my kid gets good grades, we're good, he's involved or she's involved in sports. Well, guess what? They get hurt, they get injured, they go to the doctor, they get prescribed opioids often. They have teeth extracted, they get prescribed opioids. There is really no one that's safe from this if you even take medication legitimately. You never know whether you're going to be the next one that's dealing with an issue here. This is really true. I talk to people all the time. They just don't see that pills are a problem. Doctor prescribes them. Why would they prescribe them if they were dangerous? There's a very low perception of harm for a lot of people out there, and that's what I work to break down. The reality is just this: they're just as potentially deadly, addictive, and illegal. We have kids that are passing around pills on school campuses or just outside of campuses. I don't think they really get it, that there could be some serious legal consequences. They aren't being informed of that. Our community impact is enormous. I think I've suffered the worst thing, possible in losing my child until I talk to a family that's dealing with addiction. I know parents that have had to throw their kids out on the street, almost literally, because they can't handle any more the friction and the problems that are happening as a result of their addiction. I know one dad that almost got stabbed by his son who was high on Oxycontin, who would never think to do that. People act differently when they're under the influence. A lot of trauma, and I think that a lot of the parents are dealing with long-term anxiety issues themselves, and then I see that they're moving over to self-medicate themselves out of their problems, dealing with their depression or their anxiety because they just don't have the tools and the skills to cope with the addiction in their family. I have kids that have come up to me and they've told me it's not them that has the problem, it's their parents, mom, dad. I presented in West Virginia in one of the highest hit areas of the country at a high school, and I had a young man come up to me to tell me that he was one of 14 kids in a family. Their dad died of an overdose, and he got himself into trouble with some substance misuse also and got into legal trouble. His mother wouldn't let him come home. She already had enough on her plate. She couldn't handle him anymore. So anyway, it's huge. We have to do something, and thankfully we are starting to see some federal and state and local action too. CDC guidelines are out there now. They're not mandatory, but they're good guidelines. I'd love to see all doctors adhere to them. Federal funding is starting to trickle down, but I will tell you it's not enough. So the Fed Up Coalition that I mentioned earlier, that's one of the things we're doing, is hammering for more money, we need it. But we also need that money to come down to the local level and be spent wisely. We heard also about these treatment facilities, and how do you know what the good ones are and the bad ones are? There really isn't enough, I don't think in terms of evidence-based, I don't think we really have that nailed down yet. And we have some of these facilities that are just plain money grubbers, and they are not really there for good. We have public awareness campaigns, and that's what we're building solidly, I think, in my coalition, as well as others that are involved with the California Opioid Safety Network. The data gathering tools are out there, but they need to be better. One of the things that really bothers me a lot, and I had a chance to talk to Letitia about this morning, is that we really don't know what's happening on our college campuses. That data, that you die in Arizona, as my son did, that data stays in Arizona. It does not come back to the local area where the impact actually is. So we need to find a way to collect the data and not have it be damaging or threatening, I guess, to the university setting. And we do see some concern about that. Mandatory use of in our state, the prescription drug monitoring program named CURES. That is finally mandatory to use by physicians who are going to be prescribing in certain settings, which I think is a really good thing. And we have just passed a safe medication storage and disposal program, which is really good because we need people to lock up their meds. You never know who in your home is coming in to take advantage of those medications that are up in your cabinets or maybe in the kitchen counter or whatever. And we also, again, as you've heard about, have this California Opioid Safety Network. So I'm really proud of our state for really going to the extent that we have to get this done. But and each one of our coalitions throughout the state are really working hard to make a difference within our own worlds, and we're communicating with each other, which I think is really important, to share best practices and tools that we're developing. So how you can make a difference is build us something that works, that helps us. Your work here is extremely important, and I really encourage you all to dig in. Think about the faces that you saw up here. Think about Joey and all the others that are being impacted. You can absolutely make a difference, and we'll look forward to seeing the results of your work. I'm hoping I can personally use it to make a difference. Thank you.
All right, our next speaker is the director of the UCLA Cannabis Research Initiative at the UCLA Semel Institute for Neuroscience and Human Behavior. He is going to talk to you about the intersection of cannabis and opioid use. Please welcome Dr. Jeff Chen.
Cool. All right, everybody, thanks for having me. I know lunch is coming up soon, and I'll try to keep this entertaining. I know cannabis is a very boring subject matter, so I'll try to keep you guys engaged. And so, today we're going to be going through a series of potential intersections. I'll describe the state of the evidence, and unfortunately, a lot of it's mixed at the end of the day. So what's the current state of evidence of the use of cannabis for chronic pain? What's the current state of evidence of the opioid-sparing properties of cannabis or cannabinoids? That is, the ability to co-administer cannabis or cannabinoids and reduce the amount of opioids that are consumed. What's the impact on cannabis state laws and prevalence of usage, on overdoses from opioids? How might cannabis or cannabinoids address withdrawal symptoms from opioids? And lastly, how might cannabis or cannabinoids address some of the cravings for opioids? Okay, so on the first topic of chronic pain, this is probably where we have the most evidence for the therapeutic potential of cannabis. And actually, there were two recent meta-analyses looking at all of the randomized controlled trials on this subject matter. And the Annals of Internal Medicine review found that there was low-strength evidence of the effectiveness of cannabis for neuropathic pain, and it was insufficient for all the other pain categories. Now, contrast that with the National Academy of Sciences review, which was published right around the same time, which actually found substantial evidence that cannabis was effective for chronic pain. Okay? Now, both meta-analyses agree that out of all of the chronic pain evidence, really the most evidence is for neuropathic pain, nerve pain. Which is also really interesting because that's one of the areas where, in terms of the use of opioids for nerve pain, that's an area where there isn't actually a lot of evidence for the efficacy of opioids for nerve pain. And so the idea that you have an alternative that might be effective is very promising. Also note that there's studies looking at two types mainly of cannabis products. On one hand, it's a 1-to-1 ratio of THC and CBD administered as a spray in the mouth. Okay, so that's used in a lot of these randomized controlled trials for pain. And another chunk is where they actually vaporize whole plant cannabis. And there's also been shown efficacy for that in controlled clinical trials. One important thing to note is that in terms of the vaporization of cannabis, they were using cannabis that had very low potency of THC, anywhere from typically 3 to 8% THC by weight, whereas anything you buy in a dispensary nowadays, 15, 20 plus percentage. But in these clinical trials using low dose THC cannabis, you were able to get pain relief. And you were able to get pain relief at doses where the subjects didn't really report much psychoactivity or cognitive impairment. And in fact, at the higher dose, in some of these studies, at higher dose THC levels, the pain actually got worse. You got hyperalgesia. So there's this biphasic effect that we're starting to tease apart for cannabis. So the conclusion is, it looks like there's evidence of the use of cannabinoids for chronic pain. Nerve pain is the most promising, and more is not necessarily better. You can achieve pain relief at doses where you don't have psychoactivity, and that's important. All right, let's talk about the synergy with opioids, or this opioid-sparing properties of cannabis. So there was a recent meta-analysis conducted looking at preclinical studies, and they looked at 19 preclinical studies where they administered various opioids with THC. And what they found out of 17 out of the 19 studies, there was demonstrated effect of synergy. So very good evidence from the preclinical literature, so in animal studies. But what's interesting is it depends on type of opioids. So with codeine, you have almost you need 10 times less codeine for the same amount of pain relief when you administer THC along with it, 10 times less. But for something like morphine, it's only 3 times less. You can use 3 times less morphine to achieve the same level of pain relief when you add THC. Okay? Now, what does this look like? Again, so it's opioid specific. So this gets a little more complicated now. And what does this look like in humans? Well, I'm actually going to present data from Ziva Cooper, who published the first study in humans looking at the synergy between cannabis and opioids. And she's actually leaving Columbia and joining us at UCLA, joining our cannabis initiative at UCLA. So we're really excited to have her. So in her study that was published earlier this year, she had 4 different treatment arms. So she basically had participants get no cannabis, no oxycodone. She had participants get cannabis, again, low-dose cannabis, 5.6% THC, and no oxycodone. They got placebo. Or they got placebo cannabis with oxycodone, or they got both. Okay, so we're evaluating all of these different combinations to see what happens. And another thing to keep in mind, this was artificial pain in a lab. So they took healthy participants and induced pain with them. So there's various things you can do to induce pain. You can apply pressure, you can do rapid temperature changes of their extremities to mimic pain. So what they found is when they got placebo, they had no increase in pain tolerance, pain threshold. When you gave them cannabis, they had about a 20% bump in the amount of pain tolerance, so a 20% increase in analgesic effect, you could say. When they received 2.5 milligrams of oxycodone, so very low dose oxycodone, they had about a 5 to 10% increase in pain tolerance. So again, not as much as cannabis, but they still got better than placebo. Now, when they combined the two, you had about a 50% jump in the amount of increase in pain tolerance that you got. So again, the first demonstration of synergy in humans, published earlier this year. Now, the real question then becomes, this is healthy participants where you're inducing pain. Well, what actually happens when you have chronic pain patients who are using this in the long term? And that's where we actually don't have any controlled data on. We only have some kind of prospective observational studies. And they're contradictory. So here is a study that was done in Israel, where they took 176 participants. This was an open label study. And they found that at 6 months, they had nearly a 50% reduction in opioid usage. They also reported improved pain severity. Now contrast that with another paper recently published out of Australia. They followed 1,500 individuals who had chronic non-cancer pain, who were being prescribed opioids. And they followed them over many years, and they found that those who self-reported using cannabis for pain actually had greater pain severity and no impact, no reduction in opioid usage. Now, there's a huge caveat here that I want to talk about. So in Israel, medical cannabis is very well regulated, and it's legal and it's ingrained into the culture. So a physician will prescribe medical cannabis. You'll go and get the product from a dispenser or from a pharmacy. And the people supplying the products are nationally licensed, professional, pseudo-pharmaceutical companies that are producing the cannabis to CGMP standards. So in Israel, it's very well regimented. So these 176 participants, they were getting it under the care of a doctor. They were getting standardized products, used in a regulated fashion. In this Australia study, at that period in time, they didn't really have a medical cannabis program. So these are people who are essentially buying from the black market. The products are not standardized. Are you consistently getting the same products each time? Not really under the supervision of a physician. So maybe the difference is the product varieties, how they're used, right? Okay, now let's talk about medical cannabis laws and opioid overdoses and what we see there. So this was a study published a few years ago, and what they found was that compared to control states, states that legalized medical cannabis saw resultant drops in opioid overdoses, and it was sustained over time. So in year 1, you had a roughly 20% drop in opioid overdoses compared to control states, and it looked like over time the effect actually strengthened. And on average, you had about a 25% reduction in the amount of opioid overdose deaths in states that simply had medical cannabis laws in their legislature. Okay. Now, there was a follow-up study. Oh, and actually another, I don't have the slides here, but they also then looked at Medicare Part D prescription drug spending, and they found that states with medical cannabis laws also had lower amounts of opioid prescriptions as well, based on Medicare data. Now, another study that was published earlier this year tried to ascertain what is it about the medical cannabis laws that's actually driving this effect? And what they found is that it's not so much that the law is there that's important. What is more important is how easy it is to open a dispensary, right? So it's really an issue of access. And they found that, 2 states that both had medical cannabis laws, one had very restrictive dispensaries, one had very loose dispensaries, more access, more number of dispensaries that were easier to open. You found that it was really the more liberal allowance of dispensaries that was driving the protective effect. And in fact, they actually found that the protective effects have dissipated over time. So when they're looking at the window all the way from the late 90s all the way to now, they're finding that the protective effects are actually less valuable now. It could be because the opioid epidemic is shifting, right? People aren't really going from prescription opioids to illicit. Some are starting directly with illicit opioids. That could be a possibility. Another explanation is that medical cannabis states that are coming online now are actually starting with a very regulated program. So like California legalized medical cannabis in 1996. This was not a regulated program whatsoever. Whereas states that are legalizing cannabis now are they've learned from the lessons of all these prior states. They've learned from California and Washington and Colorado. And so when they start their medical cannabis program, it is very, very regimented and regulated. And maybe that's why you're not seeing as much of a protective effect. Here's another contradictory study that was recently published that actually found that medical cannabis users were more likely to use both prescription drugs and or were likely to use prescription drugs medically, but also use prescription drugs non-medically. And so a potential observation or comment to this is that, okay, maybe folks that use medical cannabis are more likely in general to both use prescription drugs and non-prescription drugs, but that the effects of the cannabis use are still protective. So even though they're using, they might be using opioids both medically and non-medically, they're maybe using less than if they weren't using cannabis. Okay, what about withdrawal symptoms? So there's actually very robust preclinical evidence that both THC and CBD can mitigate withdrawal symptoms in animals during opioid withdrawal. And there's been a few studies where they administer THC as an adjunct. They administer it with drugs like naltrexone, and they find that you also have improved symptoms during the withdrawal detoxification period. You have improved appetite, improved insomnia symptoms, improved energy levels, et cetera. So, and if you look at, again, this is not here, but if you look at survey data, there's also observational survey data where participants report that when they use cannabis during withdrawal, it helped symptoms. So this is kind of corroborated from animal studies all the way to kind of real world clinical studies and then kind of real world observational studies. Let's talk about, and lastly with my last minute here, I'll talk about cravings. So again, preclinically, we find that CBD is actually able to attenuate opioid-seeking behavior in animals. And actually, there's been one clinical study done thus far where they found that administering CBD to individuals who are recently abstinent from opioids was actually able to decrease the amount of cravings when they showed them photos of heroin. It was actually reduced the amount of cravings. And the interesting thing is, the effects lasted for up to a week after the last dose of CBD. And so we're still trying to decipher the mechanism for this, but there's this sustained effect after you administer that last dosage. And actually, we just got a grant at UCLA to do a follow-on study where we co-administer CBD with buprenorphine and see if that can increase or if that can decrease the odds of relapse in people who are in treatment for opioid use disorder. So that's really exciting. So we're basically doing a follow-up on this study to expand the size and play around with different dosages to see what's the optimal dose. So today, again, at the end of the day, it's a mixed bag, but what's interesting today is that we have some data sets that are really exciting, some first of its kind data sets that we can apply to opioid usage. So dispensary locations over time. We can see how a dispensary might affect the impact on opioid overdoses in a geographic region. We also have total THC sales per capita that we can play around with in different county levels and see how that correlates. So again, these data sets have never really been applied to opioid data sets. So, great. All righty. Thank you very much.
All right, and our last speaker is here across the street. He is the professor of pediatrics, UC Irvine Chief, Pediatric Pulmonology Division, and the founding director of the Institute for Clinical Translational Science, and the program director of the UC Irvine Clinical Research Center. So long title, short name, Dr. Dan Cooper, please. Up. And this is not his first slide. We're giving away the punchline, I guess. Up. Uh-oh.
No, you guys edited it. No, you edited the first slide away. Okay, doesn't matter. All right, so go back to that one, if you will. The reason that wasn't my first slide is because if you could go back to the original one you put there. Yeah, when I sent this, no, thank you. The reason this doesn't work is because the first slide was the original scheduling of this talk. And it had me at 11:45 p.m. to 11 a.m. So I thought that you guys were trying to give me a message, which was either that I would talk for 12 hours, which everybody who knows me was easy for me to do. And I have 280 slides, Sean, if you want me to go on. I'm happy to do that. Or that I should talk about time technology, which is actually very, very useful. So I did come up with some time technology that I think illustrate the point about new technology. And the first is this one. When you're thinking about new technologies, as this illustrates, the technology has to be really accepted as this particular time machine was for this group of people, for those of you who saw that film. The other one is you really need to understand, this is another example of time technology that could help us deal with this, either going back or forward in time. You really need to understand the underpinnings, and in this case, the mechanism was lost completely. And then the third illustration of where technology is really, really important is in this time machine, where when the DeLorean company was ended, the ability to access the technology was gone. So the relationship to industry is very, very important. So I wanted to make those points about time. This is a little bit about me. This is just before I started doing this talk, which really got my hair all gray. And the reason I wanted to bring this out is because my research is about physical activity and health in children. And so I'm very interested in non-invasive techniques because we have to be non-invasive. I'm interested in the community as a whole because when you take care of kids, you have to be. And one of my other jobs is, as Sean mentioned, that I'm the head of our Clinical Translational Science Award, which is part of the NIH, and it's a really wonderful effort to speed up the process whereby we go from basic science discoveries to actual implementation. And this is, for somebody like me, a physician, clinician, researcher, is really what my whole career has been about. And so I say this because, you know, I look at every, the hammer looks at every problem as a nail. So the two technologies that I want to talk to you about are things that I know about and that may have some application to this really profound crisis. And I'm going to talk about two relevant technologies. This is a picture at the top here. This is Sherry Rowland, who won the Nobel Prize in 1995 for, he's the guy who discovered the mechanism of the loss of ozone in the atmosphere. He is he is a chemist, and he studied volatile organic compounds. And a lot of his work has been translated now into clinical application in looking at human breath. And we'll talk about how human breath detection and monitoring might be something that's very useful. And the second was BC mentioned the use of mobile technologies and real-world monitoring, such as physical activity and sleep, has a great deal of relevance and something that all of you might be interested as you think your great thoughts in the next 48 hours. Sean began this whole discussion with this idea that anything that we do, including implementation of technologies in new applications demands multidisciplinarity. And what I wanted to show you, this is sort of my experience with that paper we wrote about breath oxygen isotopic fractionation, something I'm very proud of because it came from the Division of Respiratory and Critical Care, the Department of Pediatrics at Harbor UCLA, and the Division of Geological and Planetary Sciences from Caltech. So to do translational work, you really have to cross boundaries and cross borders. This is a device that I found that was developed at the Karolinska Institute. It's called the SenseAbuse. And what it does is it makes available substances from human breath that you can then analyze for the presence of drugs. So the interesting thing about this is there's two sources of materials in human breath. One is volatile organic compounds themselves, which, as I mentioned, Sherry Rowland and other UCI investigators and people throughout the world have been able to measure now in the parts per billion and parts per trillion. Just so you know, there are about 3,000 or 4,000 gases that we emit every time we breathe, and they reflect our environment, and they reflect, in many cases, the medicines we take. What this device did, which is so interesting, it captured the other component of the human breath, which is the bioaerosols, which are sometimes in liquid form. And this device, which is handheld, and you can see, actually captures enough quantities of the liquid form that you can then use it through gas chromatography, liquid chromatography, and then subsequently mass spectroscopy to actually measure substances. So here's a fairly recent article that looked at a liquid chromatography and tandem mass spec method to determine 28 non-volatile drugs of abuse in the exhaled breath. So this is from that liquefied bioaerosol that they captured in that device that I just showed you in the breath. And just some examples are shown here. You get really distinct signals. This is the beauty of mass spectroscopy, one of the great advances in the past 100 years or so. And the authors wrote, the method presented here, this is from 2017, is a well-validated analytical method based on chromatographic separation and mass spectrometric analyzer for analyzing drugs of abuse in human breath and successfully analyzed real breath samples from patients. So in considering possible technological advances, this is certainly one to think of. This is from also another recent review from appropriately the Journal of Breath Research, which looked at a review of drug detection in the breath using non-invasive assessment of illicit pharmaceuticals. What I wanted to show you is some of the drugs that we've mentioned today, codeine, morphine, et cetera, all these opioids are detectable, some in particles, some, for example, fentanyl in the gas phase. And these technologies are there, but they need to be developed. And I think you can see the application of them. You know, we, in my world, as a pediatrician, a pediatric pulmonologist, I want to know if you're using your asthma medications, which are all inhaled now. And we have a method of looking in the breath to see if the evidence of the aerosol is there. And so we're now able to say, in an asthmatic patient, people rarely remember when they've taken their medications. People who use opioids are either unwilling to tell you or don't remember when they use their medications. So this gives you some grounding as to the status of the individual at that moment. The other technology is the ability to monitor real-life activities. This is a study that we did back in 1995. We were trying to figure out how to assess physical activity in actual human children. And it was this is from direct observation, and it was a method that we gained from a couple of anthropologists, friends of mine, who were studying the hunting-gathering people of the pygmy people in the Ituri forest in Zaire in Africa. And physical anthropologists are really interested in energy expenditure. And what they did was they did direct observations. They sat there, and every 3 seconds, they recorded what people did. And we did this in a bunch of kids in Westwood. It was kind of creepy, doesn't it? We were following them around and stuff like that. So we converted it to energy expenditure, and this is what activity patterns look like in real life. Now, let's fast forward in time to more recent days. We now have remarkable ability with devices that you can wear that give you just as accurate, if not better, indicators of real-life physical activity. Now, why is this irrelevant? Because it's clear that both in terms of physical activity and sleep, people who are overusing the opioids are going to have very significant and perhaps what we call pathognomonic or diagnostic indicators that there's overuse. Here's a paper from 2014, Sleep Disturbances and Pain among individuals with prescription opioid dependence. Results indicate high rates of sleep impairment and poor sleep quality among prescription opioid-dependent individuals. Pain severity was significantly correlated with sleep quality. Now, if you're wearing a device and I'm seeing you're becoming physically inactive over a period of time, maybe we can become more intelligent about this and it can alert the physician, gee, what is going on here? Something's wrong. Or with these same devices that you can wear on your wrist, you're able to deduce sleep patterns as well. I want to put a plug in because this is a real theme that we've been talking about. The concept of learning health systems. Learning health systems is a very novel way of how we can meld data science, clinical information, and the community to solve health problems. And this is a slide that comes to me from Charles Friedman, who is chairman of the Division of Learning Health Systems at the University of Michigan. And what I love about this is this shows the virtuous cycle of how we can use data. Some of the apps that you folks might develop today among physicians, the patients, the community, law enforcement, to really improve the situation. So we typically are stuck here in academia where we go from data to knowledge, we write a paper, and we think we're done. That's no longer the case. That can't be anymore. We need to also go from knowledge to performance. We have to take action, and we have to then complete this cycle by performance to data. And this is a learning health system, which is a model of continuous improvement. So as you develop your programs, think about how this is an iterative and a self-learning process. Here's an example of a study that's just coming out. This is the article that describes what they want to do. This is from 2018, just came out, using routinely collected data to understand and predict adverse outcomes in opioid agonist treatment. They call it the OAT study, Opioid Against Treatment Safety. We will use standard regression techniques to model the magnitude and risk factors for adverse outcomes, mortality, unplanned hospitalization, and emergency department presentation, and unplanned treatment cessation during and after OAT, and machine learning approaches to develop a risk prediction model. And that's the essence of a learning health system. So I want to end with that. This is, we've heard various versions of this. Lillian Wald, one of the great public health nurses of the United States of America back in the 1910s and 1920s. The great aim of education is not knowledge, but action. I also want to add something. So I see a lot of young people here, and I think that Sean invited me because I'm probably the grayest hair here around. Two observations. One is, I trained as a physician at UC San Francisco between 1970 and 1974. It was one of the times of a great heroin epidemic in this country. And one of my rotations as a resident was in the alcohol and drug withdrawal and rehab unit. And I used to sit and spend a lot of time talking with drug addicts. And the cultural change that we have witnessed over the past 40 years is really reflected. When my generation, we did not treat opioids as any kind of great pal or any kind of great friend. And when you saw those clips of a physician saying how wonderful they were, it's kind of shameful. And you really see this cultural change. It just didn't happen. The second point I wanted to make is I hope everybody understands what a great job Sean and Claire have done with this particular symposium. I rarely have seen such a great selection of speakers. Keeping us, I'm over, so I have to be over because I'm a professor, you see. So, I get thrown out of the university if I stayed within my time frame, right? But I did want to say that it is really remarkable, and I've sat through a lot of these things. I remember in the late 60s and 70s, we used to have these things called teach-ins. Probably never heard of them. Teach-ins would start at 4 or 5 in the afternoon, and they would go all the way through the next morning, and you would learn everything about a topic. This is a teach-in on steroids with the added advantage that you guys are going to come out with something that's actually going to help. And so I applaud these guys, and I think they deserve a big round of applause at this point.
Thank you. And Dan, great to know that you've blocked off your schedule through tonight. Does that mean you can join me for the inspirational midnight snack talk to everyone? You'll go for that. All right. So to wrap up now, actually an administrative thing. So after these talks, a reminder for all participants to sign in, check in with their teams to get ready for the hackathon. And obviously a very big thank you to all of the speakers we've had here. We've had, speakers who are so busy, urgently being called away. They're working on so many different things, having such expertise in different backgrounds, and we are really fortunate to have their time and expertise and support. So just to recap for some of the ideas presented here today, we started off and we talked about some of the needs around the opioid crisis. Letitia Ingram brought up the need for faster and higher quality data. And HHS is urgently requests better and faster data. We talked about many times integration of multiple disciplines from public health, medicine, law enforcement, justice system. This is it's a complicated problem. It requires a lot of different expertise, engineering, all different areas. April Rivero summed up in one slide, did a great job in summing up some other areas, 3 areas of need. One, we need a reduction in opioid prescribing. This was also touched on by Dr. Chakravarthy and Willis. We need to figure out how do we reduce the prescribing of opioids and are there other alternatives? And what happens among the patients who are already being prescribed? How do we transition? That's a current topic. We also need integration of medication-assisted therapies as alternatives and to try to help address the growing burden of overdose. We need availability of alternatives and risk reduction strategies, like finding out about naloxone availability, more exploration of things like CBD. We need to address the stigma that patients are experiencing on opioids. Many of them have been, as Kieran Gill pointed out, been prescribed opioids by their physicians, and so it doesn't seem comfortable to use traditional services like Alcoholics Anonymous. So how do we do that? How do we address those needs? Well, we've heard about different tools that are available also. We heard about big data, lots of data. We've heard about electronic health records, social media and other types of data, and online forum data and how those can be analyzed. Figelis talked to us about that. We heard about interventions like the HOPE online community and other behavior change methods. And we heard about other alternatives like over-the-counter painkillers and potentially cannabis being used as an alternative. Those should be explored. We heard a personal story from April, which really just, it's so personal and lets you connect with how she and others are feeling. And we heard about implementation and strategies, studies, and needs. We heard from Dr. Cooper on how do we study how to accelerate scale up and implementation of new solutions through things like learning health systems. And Dr. Mittman about necessary but not sufficient conditions and how to include things like peer role models, key stakeholders, incentives, and external pressure to try to drive changes in this area. Now, in planning this, we've had a head start in gaining many of those insights because we've been really lucky in having an advisory board who's from all these different areas who's helped guide us on these needs in these different areas. And so as a result of that, we've set up this morning to try to educate all of you as hackathon participants and to try to give you both education here as well as many of the tools along with data, knowledge, and key stakeholders who can help you to try to implement solutions that you've come up with. And of course, we have funding from our sponsors to be able to support that work in the future. We have, for each one of the 4 tracks, we have a $5,000 prize. We also have funding to provide the winners to go on to conferences and present their work at a conference, and continued travel to meet with the key stakeholders in different parts of the state and even federal level to help learn about how to implement these solutions. And we will follow up. We have surveys and interviews that we will conduct to learn about this process, what are the barriers to implementing the solutions that each of you come up with, and how to improve that in the future. And I think, as someone outside of my academic world, I've been involved in startups for many years now and just love that feeling and excitement of entrepreneurship and building things quickly. And I've also, through that process, been involved in spending a lot of time, often a couple of years of my life, building something that no one ever uses. And so I think one thing that's especially exciting about this opportunity is that we've partnered and we have this advisory board of key stakeholders who are so committed to trying to help each of you as teams, as entrepreneurs, as diverse groups building software to try to help so that the work that you do in just 24 hours of your time, and I don't want to, not just 24 hours because you're going to be working really hard, but they will be working with you to be able to help have your solutions implemented. They have the ability to help be champions for you if you build a good solution to address their needs. So I think that's one of, or maybe the most exciting thing about what we'll be starting here for the next 24 hours. So I'm going to leave you actually with, you've heard things here today, and hopefully it's connected with you. You've definitely you've gotten educated, you have data, you have tools, but with, as I presented, 75% of you are engineers and maybe are not personally connected to this other than through stories or maybe from April's presentation. But this is not a crisis that is separate, where there is no one who is not at risk here. So, for example, in our HOPE study that Kieran talked about, we conduct a peer role model training where we work with peer role models, as she mentioned. And one of the peer role models, so we sat around with them and each talked about their background. And one of them, he studied physics in college, went off and worked in engineering, worked in IT, and then while working in technology, he ended up suffering an accident and experienced chronic pain. He was prescribed opioids by his physician and quickly became addicted. And he was telling us there that, you know, he knew something was wrong. I mean, he's very intelligent engineer, and within 9 months, he was hanging out with motorcycle gangs to get black tar heroin. This is not something that is where anyone is immune to this. It affects everyone. It affects all of us. And I think we need to remember that, and all of you remember that as we go into the next 24 hours. Now, we'll be around. Again, I want to give please, everyone join me. Give a big round of applause for our speakers. Thank you so much, speakers. Speakers, please, before you leave, we have gift baskets for you. We have a grab gift bag for you to take. And know for all the participants, as we're gonna you know, get to talking right after this and get into the logistics of it. Know that this is just the beginning of having this group of key stakeholders. So many of the speakers here, the advisory board, they have said, not only do we want to know what happens after this 24 hours, but we want to stay involved to help address these solutions and help try to implement successful change in this area. So we're really excited about all of you and what you have to bring, and we will talk to you after lunch.